Testing 1 2 3. Test 1 2. Testing. Test. Testing 1 2 3. Test. Testing. Test 1 2. Testing.
Okay, we're going to go ahead and get started. Good morning. I'm Dr. Chris Wood. This is Kerry Konoski from the Kidney Cancer Association. Welcome to MD Anderson and our, how many have we done?
10, 11.
I think this is our 11th annual patient conference here at MD Anderson. If you have any housekeeping issues, please see the conference staff outside. My assistant Carol is out there and will be happy to assist you. The conference today is being produced as a live YouTube broadcast as well as a videotape for a webcast to be posted on the Kidney Cancer Association website at a later date, so don't feel you need to take notes. As we are streaming live today during our question and discussion session, I'd like to ask you not to identify yourselves or any patients that you may reference during questions presented to the panel members. And if you'd prefer not to be videotaped, please let us know. Please silence all the electronic devices during the duration of the day. If you need to place any phone calls, just step outside the conference room to avoid interruptions to our taping. In terms of support, we'd like to thank Pfizer. They've continued to support us on an annual basis for this conference. Carrie, do you have anything to say?
I just want to thank everyone again for being here with us today, and to thank Dr. Wood and Carol and MD Anderson for hosting this meeting. It continues to be very successful. We're fortunate that we're able to do the live webcast as well so that we can continue to reach hundreds of patients all over the world. As Dr. Wood mentioned, if you have any questions at all, I will be sitting outside at the registration table today and would love to chat and meet all of you, so thank you.
All right, without further ado, we're going to go ahead and get started. So the goal of the conference is basically to present the management of kidney cancer, really soup to nuts, from the management of a small renal mass to the management of patients with metastatic disease. So we're going to start off with Serena Mateen, one of my colleagues on the urology faculty, who's going to talk about the evaluation and management of small renal masses. Serena?
Good morning, everybody. Thank you for coming. I'm setting a timer. I wasn't playing with my telephone. I want to make sure we stay on time and leave plenty of time for questions. So what I thought I'd do over the next 25 minutes or so is go over the evaluation and management of a small renal mass. This may not apply to many of you who are here as survivors, but yet now you are a de facto source of information for your family and friends also who may come to you with their own personal dilemmas if they're diagnosed with a tumor in their kidneys. So hopefully this will provide some background information for you. I'll spend a little bit of time on evaluation and really focus on management aspects. So in terms of evaluation, briefly, what we as a standard baseline like to do is get a history and physical. Talk to patients. We want to look for other signs and symptoms that may need additional workup. In terms of a small renal mass, they are invariably nearly all silent. They're usually caught incidentally. So really what we're also trying to look for with the history and physical is to assess overall health, what we call competing risks. I'll tell you what that means, and tolerance for anesthesia and surgery. If you don't mind, I'm just going to check one thing here to make the pointer more friendly. There we go. We'd like to get a scan of the abdomen. That's where the kidney is. So if there's not one, if there's, for example, just a simple ultrasound, we'd like to get something more detailed with a contrast-enhanced CT or MRI. We don't really have to cover the pelvic portion in many cases, and in fact, insurance will refuse to pay for it, or if what was done, sometimes they'll not reimburse that. So in today's age of much more attention to cost, that is just one little detail to point out. And then we like to look at the chest, either with a simple chest x-ray or, if indicated, a CT scan, because kidney cancer, as many of you might know, it likes to go to the lung more so than anywhere else. Very unlikely to do that in the case of a small tumor in the kidney, but still it's just a baseline evaluation. And a chest x-ray, pretty simple thing, fairly low radiation exposure. And then we get blood work, primarily to look at the metabolic profile, and more importantly to get the serum creatinine level, which we can use to calculate kidney function, which we call the estimated glomerular filtration rate, or GFR, which gives us an idea of what the overall kidney function is. So I mentioned this idea of competing risks, and it's something that we're much more aware of now than we were, let's say, 20 years ago, where we sort of had a one-size-fits-all approach to patients with kidney cancer. And the idea here is that there are a variety of factors out there trying to kill patients. One of them is the tumor. And if it's cancer, it could grow. Worst case scenario, it can spread and become incurable. Of course, that's part of our goal, is to try to avoid that. And in the process of growing, maybe it would destroy more kidney and patients would lose more kidney function. On the other hand, what's pulling on your life are these comorbidities: diabetes, high blood pressure, heart disease, strokes, etc. And so with that, there is a risk of us intervening because maybe there's silent heart disease that's undiagnosed. We don't want to go in and treat something and have you risk getting a heart attack because we didn't think thoroughly enough about that. There's the idea that maybe what we're going to do isn't really going to help you from a cancer perspective because there's so many other medical conditions that that's really what's going to be the end of life. And then secondly, the issue of things like diabetes or kidney stones harming kidney function already. And on top of that, if we're going to intervene, then we may cause more loss of kidney function. So these are a few of the competing risks that we consider when we're seeing patients. So how does that translate to real life? Here's a study that looked at patients who were treated for a small tumor and then looked at their comorbidity status. So how sick were they? So a Charlson 0 means they're pretty healthy. A Charlson 3+ means, you know what, they've got a lot of medical conditions. So what's their survival of these different groups like? I'm not going to look at the bigger tumors. Let's just focus on this row. And what you're going to see is blue and red. Blue means the risk of dying from non-kidney cancer causes. Look at how overwhelming that blue is compared to the red. The red is the risk of dying from treated kidney cancer, not that they watched it, but they got treated. But the point is that once it's treated, the risk of dying of kidney cancer is so incredibly small compared to the overall other risk. And it makes you wonder that maybe some of these patients did not necessarily have to have treatment for this, especially once you get to these issues, to these patients who have many more comorbidities and have such a much higher risk of dying. Now, if you look down here with a smaller tumor in a healthy patient, you can see that the risk of dying of kidney cancer is almost equal to dying from non-kidney cancer causes. So obviously the risk-benefit ratio there is different. But again, we're just focusing on the small tumor mass, which we define as those being less than 4 centimeters. So the other factor is that we're born with a tremendous amount more kidney function when we're infants and toddlers and teenagers, but we lose it over time. As we get older, just aging processes, and then if you add to that diabetes and high blood pressure, then you lose it even more quickly. And unfortunately, unlike the liver and lizard tails, we don't regenerate kidneys. Okay, that would be a huge advance if somebody figured that out. But kidneys don't really regenerate. So once it's gone, it's gone. The other question that we get is, why do I have to have this injection during my scan? Do we really need it? And here's to give you a couple of examples as to how big of a difference it can make. Here's a patient I actually saw just recently, and initially they thought the patient had a kidney stone, so they got a scan. What they see is a cyst in the kidney, no big deal. We don't really worry about those. There's a little something here, but this is a non-contrast study. It's basically like going in a dark room and trying to make things out when it's sort of everything's kind of dark. When we give contrast, it lights up the blood vessels, it lights up portions of the kidney, and tumors tend to light up either more slowly or more quickly than the rest of the kidney, so then we can tell what's going on. So suddenly you see that there's something here. The cyst is there, it's much more pronounced. We're not really worried about the cyst, but now we see this tumor. And to just get a little bit more detailed with you, it's not just even about giving contrast, but it's about doing the scan in a proper way so that the timing is done well. So that's why sometimes when patients come see us, we emphasize, look, we want to get a scan here, or we have to repeat your scan, or your scan wasn't quite what we needed when they're done elsewhere. And it has to do with these important details where the devil lives, because then if you skip it, then you may miss something. And so here's another example. Here's a non-contrast study. You see a couple of little things going on here, but overall the kidney looks kind of normal. When we give contrast, that you see this black spot, you see this looks a little funny, and this is done in an earlier phase after the contrast is given. Maybe this is done about 4 or 5 minutes after the injection. But then if you give it a little bit more time and let that contrast circulate and just sort of equally distribute through the tissues, then we get a better picture of what's going on. And suddenly, this was nothing. This is just some fat inside the kidney. But lo and behold, there's a tumor there in the kidney that was completely not seen and not really well. This could have easily been skipped. The radiologist easily could have missed it. Any of us could have missed it. But now it's really well defined where it is. Okay? And the other thing I wanted to show you is that the scans don't really help us differentiate between kidney cancers, the most common being clear cell or papillary, and they don't really help us distinguish that from benign tumors, such as oncocytoma or metanephric adenoma, which is an unusual one that we sometimes see. They all pretty much look the same on CT scan, with some rare exceptions. For example, sometimes we can kind of guess in educated fashion that it's a papillary kidney cancer. So just to give you some of that baseline. So we talked about considerations, kidney function, patient's health and vitality, competing risks, and then we'll talk about treatment options and some of the clinical guidelines that are out there. And then I'm going to close up with surveillance after treatment. So we have certain guidelines from societies. There's the American Urological Association, AUA. There's the National Comprehensive Cancer Network, NCCN. And then there's the European Association of Urology, the EAU. The point I want to make about this is that the guidelines that these groups have proposed, you'll see a lot of similarity. There's some subtle differences. They're not based on hard evidence. They're based on a group of people coming together in a room, and it's consensus because we don't have great high-quality scientific evidence. And what I mean by high quality is like a ton of randomized studies, for example. We have very few of these in kidney cancer, actually, especially surgical management. So a lot of times it's based on the strongest personality in the room, or the most senior person, and how those discussions go, and that's what we call consensus. So in terms of the American Urological Association guidelines that I was a part of and helped develop in 2009, at the time we considered partial nephrectomy a standard approach, which means this is pretty much, top-tier choice. Radical nephrectomy was also standard because we couldn't achieve agreement on whether it should be maybe a level lower because we'd lose much more kidney function with that. And then active surveillance or ablation was given as a recommendation, which is yet a step lower of a guideline. And then an option is really like bottom. It's like, yeah, you have this option, but, kind of really, can you please think about it, is what that means. These are all euphemisms in terms of providing guidance to the urologist. The NCCN is a little bit more clear. They prefer a partial nephrectomy for a small kidney tumor, a radical nephrectomy only if a partial is not feasible, surveillance in selected patients, and ablation in patients who aren't surgical candidates, and somewhat similar for the European guidelines. So those are some of the options that we're going to talk about next. We're not really going to, at the very end, I'll talk about radical nephrectomy very briefly, where we remove the whole tumor, and it's still an option for very big tumors or people with multiple tumors in a kidney. But I'll talk about open partial nephrectomy, robotic partial nephrectomy, which we're doing more and more often, ablative therapy, and also active surveillance. We'll actually go in this order. So that's a lot of options, and so hopefully I haven't lost you, and if I have, I'll make it clear by the time we're done. Before we get to those, the other question that comes up is what's the role of biopsy? That frequently comes up. Patients who have dealt with cancer before frequently ask. For patients who haven't and it's their first exposure to medicine, they're worried that maybe the biopsy is going to spread cancer, and we have to allay those fears. Traditionally, what we have done biopsy for is to rule out maybe spread to the kidney from something else, like lymphoma, or if the patient, for example, has another cancer, and now that we find something in the kidney, we worry maybe it's spread to the kidney. So biopsy in that setting is pretty good, and for decades we had considered that an option. To use it to diagnose what the actual tumor of the kidney is not something that we've felt confident with until the past few years, because techniques have gotten better. Both the biopsy techniques have gotten better, but also on the other side, sort of in the back door, behind the back door, where the pathologists are working, they've gotten better at being able to tell what these different tumors are. Because not only do they look the same on CT scan, and they look very similar when we cut into them and look at them, even under the microscope, sometimes they can look similar. And again, that devil is in the details for them to be able to pick apart those specific factors which identify them as cancers or benign tumors. So things have gotten much better over the past, I would say within the past 10 years, maybe even a little bit less. I think our accuracy is probably around 90%, depending which institution you look at, a little bit higher, a little lower. Occasionally still get a non-diagnosis from a biopsy, but much less frequently than we used to. And of course, with contemporary techniques, we really don't see this issue of it spreading any cancer. There is some risk of bleeding. That risk is pretty low in good hands. The other little important detail is that there's a couple of different biopsy types. In areas where they're not very comfortable with doing this, all they do is basically an aspiration, which means all they're doing is sucking out some fluid from inside the tumor, because this way they can use a tiny little needle and the risk of bleeding is less and they're less nervous about it. The problem with that is that it gives the pathologist, who then has the obligation of trying to diagnose this, very little tissue to go with. And so with that, it's not unusual to get a non-diagnostic result. They say, well, the cancers look blue. So it could be cancer, it could be not cancer. It's hard for them to tell. With a larger needle, they can actually get some more tissue. And so not only does a pathologist have more tissue at that point, but they can actually do these new chemical stains that color different molecules different colors, and those molecules are associated with either cancer or benign tumors, and they can actually do panels of 6 or 8 of them. And then based on the combination of those, they can actually, with pretty good confidence, say, hey, this is cancer, this is not cancer. So biopsy is pretty good for certain things. It can tell us, for example, clear cell type versus the non-clear cell type of kidney cancer. It's not quite as good for telling high versus low grade. And then if you want the exact grade, like 1, 2, 3, 4, that gets pretty bad. And then if you want to look for the rare, very aggressive variant, like what we call sarcomatoid, it's really not good for that. So you have to think about what you're looking for and order it appropriately. And we don't do it in every patient, but sometimes we consider it when we think it makes a difference. And here's an example. Here's an elderly patient that I saw, very poor kidney function. Patients usually think of GFR as a percentage. It's really not. But it helps to think of it that way if you want to. It's reasonable to say that the patient has about 30% kidney function compared to normal. And it's a tumor that we found, incidentally, that really is a size where we're not too comfortable watching it. So we discussed doing a biopsy, and it was done under MRI. You don't really see the metal because it doesn't show up on MRI. But they did both an FNA, an aspiration, and again, we did not get a diagnostic result from that, but they also did a biopsy where they got tissue and they did multiple stains, and what they're favoring is an oncocytoma. It looked like an oncocytoma, and the stains confirmed that this was consistent with one. So we got a pretty confident diagnosis. This is a benign tumor. It's not going to spread. It's not going to harm the patient, except that it may grow over time. It may. So we kind of want to keep an eye on it. But the bottom line was that we felt very comfortable telling the patient, you know what, I don't think you need to have anything done. Why don't you come back in a year and we'll take a look at it and make sure that it's not going to harm your kidney function. So it can make a difference depending on the right setting. So it goes to this idea of active surveillance for certain patients. Now that was a benign tumor, not a cancer. And so when we do active surveillance, quite frequently we're doing it either for known or presumed small kidney cancers. And this was something that started to be popularized in the late 90s. We did not have much information before then because basically somebody showed up with a tumor in the kidney. It didn't matter how big it was. That kidney was out. And so we learned over the time that, maybe we don't have to remove all of these, and maybe we're harming more patients by destroying their kidney function when we do that. And in fact, multiple studies have been published, even more than what I show you on the slide. And what these slopes show was the rate of growth of these tumors. And on average, what we see is about a 0.25 to 0.45 centimeter growth per year. So we take that upper limit of that, 0.5 centimeters, as sort of the maximum we're willing to accept when we're watching these tumors. The other piece of information that I'm not showing you is several studies that show that when cancers are less than 3 centimeters, the likelihood of spread is exceedingly low. Doesn't mean it doesn't happen. It just means that the likelihood is so low. It's probably less than 1%. And so for these smaller tumors, we're fairly confident that we can usually watch them at least for some time, depending on the patient's scenario, if we need to. And so generally, and if we look at the overall publications, a 2% rate of metastatic disease, but then if you look at these cases, they are all, most of them are bigger tumors. They weren't exactly less than 3 centimeters and some other factors. And of course, it's associated, again, larger tumors and those that grew more quickly were the ones that were bad players. So you do have to keep an eye on it. This is our own data. Somewhere around 2006, 2007, we started a registry for patients that we put on active surveillance. And this shows actually the growth of tumors over the course of 2 years. Each little column here is a tumor, single tumor, and how much it grew over the course of 2 years. You can see that the overwhelming majority grew 1 centimeter or less within the course of 2 years. There are a few bad players that we caught along the way, and we had to intervene. You can see that some of them even shrink for reasons that we don't fully understand. So the other question that comes up is it risky to delay management? And again, metastatic disease, at least in our situation, is exceedingly unlikely. And if we do have to intervene, we usually haven't burnt a bridge. We still have all these options available. And whether it grows or not doesn't tell you if it's cancer. We see cancers not grow, and we have benign tumors that we biopsy that we know are benign, and those will grow. So the fact that it doesn't grow or does grow doesn't tell you much about what it is. So it's a pretty reasonable treatment options for very select patients. Either they're unfit for surgery, there's competing risks. We have a few that just flat out refuse surgery, so we watch it. It does require personalization, and the patients do have to agree to come back to get it followed up. I want to spend a couple of minutes talking about ablation, and with that I mean either freezing the tumor with cryoablation or heating it to very high degrees using radiofrequencies. Cryoablation has been around much longer. And the idea there is that basically we can puncture the tumor with a specialized probe. This shows it being done laparoscopically, although the majority of these we now do percutaneously. An interventional radiologist, who's our collaborator, puts it through the skin while the patient's asleep under MRI or CT and can guide it right into the tumor. And basically what you get is an ice ball that essentially destroys all that tissue. And then we leave everything there, and then what we have to do is basically get scans, over about 3 of them over the course of the first year. This shows the tumor beforehand. At 1 month, you see how the kidney is white. There's contrast, but there's no white in the area that we treated, meaning there's no blood flow, no life. So that's good in this case. And over time, what we'd like to see is that the area, not only does it have no blood flow, but that it shrinks. And that gives us confidence that it's fully treated. Radiofrequency ablation is the same idea, except it heats the tissue. And this is this shows this umbrella-shaped wires are what actually it withdraws in this. We put the probe in, and then we expose those wires, and that's what causes the radiofrequencies. You see a bunch of steam being generated because it's heating up the tumor to very high degrees. And then that's it. Once we think we've gotten the whole thing, again, actually this shows it being done percutaneously through the skin without even any surgery. And then same thing, no blood flow, and over time we'd like to see it shrink. So we have to get scans afterward. That's one downside of doing this procedure. The other downside is that even though the results are pretty good, these numbers are not quite as good as surgery, as I'm going to show you. But that's also in the short term, because when we did these analyses, we did not have long-term follow-up like we had with surgery. So the techniques have gotten better also over time. So we reserve this for that reason for elderly patients or those who are higher risk and maybe we have to intervene. A lot of times I'm treating patients who were on active surveillance and the tumors are growing and patients are nervous and they say, you know what, I think I want to get it treated. And we're still kind of worried about their medical situation, so then we fall back on this option. And there has to be a verbal agreement to all of these factors with the patient in terms of the biopsy before, possibly after, and then making sure they come back for follow-up. The one thing that does not relate to small kidney tumors, and you may hear about it later today from one of our medical oncologists, and what we're very excited about, this idea that we can kill the tumor and keep it in place. What happens is you're creating this tremendous inflammation and an opportunity for your immune system to maybe start recognizing that there's a cancer there. Because up until that point, the cancer has been able to create this immunogenic wall where it doesn't allow the body to recognize it. So we actually have this clinical trial that just opened, and the idea was fairly novel, although novel in that we were able to get it approved and done, but it's something a lot of people have been trying to do. But the idea that patients with metastatic disease, we can actually perform ablation in one area where the tumor is, and then give them this new generation of immune compounds that basically allows the immune system to unleash its force against the rest of the cancers. And so we have this trial that's opening up, and it's basically after the treatment is done, we go in and remove the primary kidney tumor, and then we continue the treatment with the immunogenic compound afterward if we see that there's a benefit. I want to spend the next couple of minutes talking about partial nephrectomy. It's a very good option, and it's what we consider the reference. This is an example of a patient with essentially a solitary functioning kidney. The other kidney was shrunken down, not working well, was sent to me with this large tumor. And in cases like this, we can really do a complex but quite effective partial removal, be able to preserve the majority of the kidney. And as it turns out, actually, that was a benign tumor. The patient's kidney function was totally unchanged. Here's another situation of a tumor that's deep inside the kidney, surrounded by critical structures. This is where the urine's collecting. The blue arrows show where the tumor is. Here's again the tumor, a different view. This is the urinary collecting system. And then there's also, in these red arrows, point out all the blood vessels surrounding the tumor. So the patient was given the option of attempting a complicated partial removal versus removing the whole kidney, and the patient wanted to have the kidney try to be preserved. And that's what we did. It's a fairly complex approach. We have to do ultrasound to see exactly where the tumor is because we don't see any surface landmarks. We then have to start doing this microdissection of the blood vessels and the collecting system away from the tumor. And then we actually stop the blood supply to the kidney. That's why the kidney looks pale here. And then this way we can work in a bloodless field while we're cutting through the kidney and make sure with every cut that we're not getting into tumor. And here it is. You don't even see any cancer because it's all surrounded by normal tissue. And what we can do is preserve the majority of the kidney. This shows the kidney after the tumor's been removed, blood vessels that are tied off. And then we reconstructed, reestablished the blood flow. You can see the pink kidney's nice and pink. This is what the cancer looked like. It was a clear cell renal cell carcinoma. And you say, yeah, that's all fine and good. How did this patient do? Well, this is the CT scan 6 years later. She's doing great. Okay, no evidence of recurrence of the kidney or anywhere else. And we can do this for very complex cases, solitary kidney with very big tumors, if the anatomy is appropriate, or in cases of genetic syndromes where there's multiple bilateral tumors, and try to do these complex resections. So it is the reference standard, and we have very good data showing that it's extremely effective, and it's a good cancer operation. In the old days, we used to make these huge incisions. Not necessary. Most days, most of the time, we can really do these through fairly small incisions. Truth is, it's still, an incision that is probably not the nicest for the patient. And so what's happened over the past several years is these minimally invasive approaches, laparoscopy initially, now robotic laparoscopic surgery, where we can actually perform a lot of these through smaller incisions. This is done with a machine that allows us to do the surgery in a more effective and simpler fashion. The surgeon sits separately while an assistant helps at the bedside. The surgeon's looking at this three-dimensional view, and with these controls, has the ability to manipulate these micro-wristed instruments that are attached to this part of the machine, and that they're inserted through these punctures into the body. This machine does not operate independently, so the surgeon on the other side really needs to know what they're doing. And it's, in fact, a little bit more complex than doing open surgery and requires more training. I'm going to skip over this video because I have a couple of others. But we can also do some of these complicated approaches with the microdissection. Here's a tumor that's in close proximity to the blood vessels of the kidney. This video is sped up, so it looks like I'm working super fast. I don't work that fast. Chris Wood might work that fast. I don't. But basically what it's showing is dissection of these blood vessels away from the tumor. You don't even see it because it's covered. We keep the fat covering it. And then we can basically, over time, with additional dissection, essentially then remove just that diseased part of the kidney, have minimal blood loss, and feel very confident about the resection. And we've done this many, many times, very complicated cases. Patients are sent to us, or they come to us saying they can't save my kidney. Do you think you can remove the tumor? And quite frequently we can. And sometimes we can do this robotically even. So all cases that we've done robotic partial removal with negative margins and very good outcomes. So far we think that it replicates open partial nephrectomy. It's a good minimally invasive option. Surgeon experience, again, is much more important than the machine that's used, okay? The machine is just an enabling tool. To finish up, radical nephrectomy, not really a role for small renal tumors. In fact, they're one of the few randomized studies done in this disease was looking at doing a radical versus partial nephrectomy for tumors less than 5 centimeters. This was done in Europe. They only accrued 541 patients out of the 1,300 that they were supposed to enroll. The problem was that very few patients actually died of kidney cancer over the course of 9 years. Most patients died of cardiovascular disease. And there was a lot of limitations from this study. So basically, after all of this work and all of this effort, there's unfortunately not much we can get away with in terms of information with this, except to say that we think they're about the same, so why aren't we saving more kidneys? We did a patient-reported outcome study here. It's one of the largest ones done. The point I want to make about that, so what's unique about this is that we actually asked patients about how things went. And not just asked them in clinic, but we had these standardized questionnaires. And the point I want to make is that what patients really worry about most is really after 1 year, they don't care about the scar so much, they really worry about cancer recurrence. And so the minimally invasive options are great options for the short term. And, for the long term, we just need to think a little bit more globally. And it's important for us to think about that because we sometimes put too much value on how much you care about your scars or some of the pain after surgery. But really maybe what we need to consider is what happens 1 year later or 3 years later. There's really no role for removal of lymph nodes in terms of small renal tumors. I'm going to skip over this. If you have questions about it, we can go over the Q&A portion. Surveillance, I'm going to skip also because I'm at 30 minutes actually, and I don't want to go over. But basically, it's based on the theory that if we catch recurrence of cancer early, that maybe patients will do better. Believe it or not, we don't really have any studies that prove that. But in our heart of hearts, we feel that it does make a difference, and I know you do too. But actually, there's not much scientific literature for that. So bottom line is that what we want to do is do a risk-adapted approach. Patients who are low risk, try to minimize the burden of radiation and cost and time. But for those who have higher risk, try to catch the recurrences early. And so there's AUA guidelines that make recommendations. They're not perfect. We may be missing up to 30% of recurrences, but many of us feel that maybe they're also misguided because there are way too many scans for the low-risk patients and not enough for the high-risk patients. And then there's the cost issue. So I'm going to finish just to tell you that basically the idea with all these options is that we can really individualize care, whereas 15 years ago we didn't. It was a one-size-fits-all approach. And so we think we're delivering better care and really approach this in a much more global way for the patient. Thank you. We'll just spend maybe 2 or 3 minutes on questions, you think, or do it later? Great.
So I'm going to talk a bit about the management of locally advanced disease. So this means that tumors that are more advanced, more larger, potentially involving the lymph nodes, potentially involving the venous system, that are associated with a worse prognosis as compared to those tumors that Dr. Mateen was talking about. So I'm going to touch a little bit on adjuvant therapy. Adjuvant therapy basically means patients always ask, is there something that I can do, some medicine I can take, some radiation I can take that will decrease the risk of recurrence? That's adjuvant therapy. And then talk a bit about node dissection and then management of venous tumor thrombi. So just a word about adjuvant therapy. There is none. There is no role for chemotherapy or radiation or targeted therapy or any therapy after surgery in the absence of clinically detectable disease. So if you do not have obvious evidence of metastatic disease on your CAT scan, there is absolutely no role for systemic therapy or radiation after surgery. That's not to say we haven't tried. And actually, MD Anderson and other centers have done clinical trials that have examined a variety of different agents, including vaccines, immunotherapy with interleukin-2 and interferon, a variety of different chemotherapy regimens, and most recently, the targeted agents sorafenib and sunitinib, which have shown so much promise in the setting of metastatic disease. But what we were able to show with a very large, literally international clinical trial is that they don't decrease the risk of recurrence. So when patients have surgery, it's not uncommon to have them asking, in the recovery room, am I going to need chemo? Am I going to need radiation? The answer is no. None of those agents work. So moving on to lymph node dissection, what are the clinical questions that are relevant with regards to whether or not a lymph node dissection should be performed? First, obviously, who should have one, or when can it be avoided? Should it be based on tumor size, stage, histology, or on the size of the lymph nodes based on imaging or intraoperative assessment? There's debate about what is an adequate lymph node dissection. Should it be just the hilum where the blood vessels go into the kidney? Should it be clearing off the ipsilateral great vessel, the vena cava or the aorta? Should it be a full bilateral dissection? There's no real agreement on what constitutes an adequate lymph node dissection. And then the last question is, can an adequate lymph node dissection be performed minimally invasively? More and more, as Dr. Mateen pointed out, we're doing these surgeries minimally invasively, and it becomes a question as to whether or not you can adequately do a lymph node dissection using that technology. So this is going to be a little bit of a case-based approach. Here's a patient you can see has a very tiny little tumor sitting on the back of her right kidney. And I think we can all agree that this patient probably is not going to benefit from a lymph node dissection. Arguably, she may not even need her primary tumor treated, as Dr. Mateen had pointed out during his lecture. A biopsy may help us guide further therapy, although there are some exceptions where even these tiny tumors, if they have these histologies, can behave in an aggressive manner. And now here's another patient with a very large locally advanced tumor involving the right kidney and actually has evidence of clinically involved lymph nodes. You can see there's some enlarged lymph nodes here and here. This is the aorta. There's some nodes on the side of the aorta as well. So can we all agree that basically in this setting we're probably going to perform an aggressive lymph node dissection, although the benefit really is unclear? The knowledge of histology may play a role, but arguably surgery for this patient with an aggressive resection is his best chance at cure, if cure is possible. And we can argue about whether that's the case. But here are some cases where the role of lymph node dissection is very unclear. So here's a patient with a locally advanced tumor involving the right kidney, no evidence of any lymph node involvement at all. Here's another patient with a very large tumor involving the right kidney with no evidence of any lymph node involvement at all. And the question is whether or not this patient should undergo lymph node dissection, and would they benefit from it? Well, level 1 evidence, which means, based on clinical trial evidence that I'll show you, there is no role for a lymph node dissection in these patients. It's quite possible that just removing the kidney may remove lymph nodes as a sort of a collateral damage type technique. People argue that we should remove lymph nodes to better stage patients, and staging may be relevant in predicting prognosis and stratification for adjuvant trials, but as I told you, knowing the stage doesn't mean that we have some magical treatment that we can give that patient to decrease their risk of recurrence. We don't have any. And really, the clinically relevant question is, are these patients likely to fail regionally, meaning in the lymph nodes, or distantly, meaning removal of the lymph nodes is not going to change their outcome, or both? Well, the data and literature would suggest that if we look hard enough, we will find evidence of nodal disease. This was a study that was published some years ago, and what they noted was in patients who had locally advanced tumors, if they removed more than 13 lymph nodes, the rate of positivity was almost 1/3. So nodal disease does exist and does occur, and arguably you would believe that if we can remove it safely, that patients would do better, but there's actually no prospective evidence to suggest that that's the case. These are data from the Mayo Clinic where they looked at where lymph node or where kidney tumors metastasize, where the nodes are positive, And this has helped better frame what actually constitutes an adequate lymph node dissection. So they noted that in patients with right-sided tumors, the overwhelming majority of lymph nodes are going to be in the right or in between the aorta and the vena cava, and very rarely will they metastasize over to the left-hand side. And the same is true on the left-hand side, where very rarely will they metastasize to the right. So we know where the positive lymph nodes should be, and we know what nodes have to be removed to adequately detect them. The question is whether or not we're going to impact outcome by doing such a thing. These are data looking at sentinel lymph node detection. Basically, they inject radioactive material into the primary tumor and then look where that radioactive material goes. And again, it demonstrates basically the same findings as the Mayo Clinic study did, that the nodes will end up on the ipsilateral side as well as in between the vena cava and the aorta, suggesting that we, again, know where the nodal disease should exist. The question is whether or not removing it is going to change a patient's outcome. The vast majority of the studies looking at lymph node dissection are retrospective. These are data from the University of California, Los Angeles, where they noted that patients who had no evidence of clinical node involvement, it didn't really matter whether or not you did a lymph node dissection, their outcome was exactly the same. But for the first time, their data suggested that in patients who had clinical evidence of nodal metastases, meaning that they had enlarged lymph nodes, if you remove those lymph nodes, patients did better than if you left them in place. We did a retrospective study looking at the role of aggressive surgical resection in patients who had positive nodes. We identified out of a group of more than 3,000 patients, 68 patients who had positive nodes in the absence of metastatic disease. So it's actually quite rare to have lymph node metastases and not have other sites of metastases, again, suggesting that lymph node dissection may not play a major role in helping patients survive their disease. What we noted was that those patients who had papillary histology had a better outcome. Those patients who only had one node that was positive as opposed to multiple nodes had a better outcome. Those patients who had sarcomatoid features had a worse outcome, and their performance status, meaning how functional they were at the time of surgery, played an impact in terms of their outcome. But what we noted was that almost half of the patients that we operated on were disease-free at 12 months. And you might say, wow, only half. I would argue that these are patients who have obvious evidence of metastatic disease, and that the fact that half of them were disease-free without any additional treatment at 12 months is pretty remarkable. There is one randomized trial that was done over in Europe where they asked the question, does lymph node dissection play a role in the treatment of patients with kidney cancer? And so basically, patients with kidney cancer were randomized to either get a lymph node dissection or not get a lymph node dissection. It was a very large trial. And unfortunately, at the end of the day, they were unable to demonstrate a benefit of lymph node dissection in patients with kidney cancer. But if you look a little closer at the trial, you'll notice that the overwhelming majority of patients that were enrolled in this trial were actually the least likely to harbor lymph node metastases. And in fact, the incidence of lymph node metastasis in this trial was only 3%. So while this trial was a negative trial and suggested that there is no role for lymph node dissection, others would argue that this trial is underpowered to actually demonstrate a difference and actually should be redone, focusing on the more advanced stage tumors that are more likely to harbor nodal metastases. The group from Mayo Clinic were able to demonstrate factors that predicted for nodal metastases, including nuclear grade, the presence of sarcomatoid dedifferentiation, tumor size, tumor stage, and the presence of histological tumor necrosis. And in fact, at the Mayo Clinic, all kidney tumors are sent for frozen section at the time of surgery, and if they have a variety of these different features, it triggers a node dissection. Basically, anybody that has more than two of the features that I outlined earlier are scheduled to undergo a lymph node dissection with a higher incidence of nodal positivity detected. These are data from over in Europe where they tried to predict those patients most likely to harbor nodal metastases, and what they noted in their study was that those that had an advanced T stage, evidence of clinically positive nodes, meaning enlarged nodes on CAT scanner at the time of surgery, the presence of metastases, and tumor size all were predictive of patients having nodal metastases. Last year, we published our experience trying to predict patients who were likely to harbor positive nodes, and we noted that performance status, the presence of clinically enlarged nodes, local symptoms related to the tumor, and LDH were all predictive of having positive nodes at the time of surgery. And so moving forward, we can use nomograms such as this to try and better identify patients who are likely to harbor nodal disease and benefit potentially from a node dissection. So here's a patient with a locally advanced tumor involving their right kidney, and this patient's likely to have a laparoscopic surgery. And really the question is, can an adequate lymph node dissection be performed laparoscopically, and what exactly is adequate? I would argue that in the vast majority of cases, this patient will not undergo a lymph node dissection and just have their kidney tumor removed with the kidney. Here's another case of mine that presents the potential problems with not performing a lymph node dissection. This was an 81-year-old gentleman who was undergoing evaluation for a pulmonary embolus. None was found, but he had an incidental finding of a right renal mass. He had Novus and metastatic disease, and he had what I would classify as a surgically hostile abdomen. He had multiple previous surgeries, and basically I was not looking forward to going through his abdomen to try and take out his tumor. Here's the tumor involving the right kidney right here, and so what we decided to do, instead of going through the abdomen and potentially causing all sorts of problems with his intestines and his stomach and his colon and so forth, we went in through a flank incision and just removed his kidney. And there was the pathology. It was a type 2 papillary kidney cancer that was invasive into the renal pelvis and renal vein, but we had negative margins. Everyone high-fived. The guy did well. He got out of the hospital and went home. But then 2 years later, here is a positive node sitting in the middle of his, between his vena cava and his aorta. And arguably, if I had, bitten the bullet and taken the patient to the operating room and went through his abdomen and did an adequate node dissection, this complication would not have occurred. So we had to take the patient back. He was now older. He had more medical problems. And we identified that 2 of 28 lymph nodes were positive for metastatic disease. So I would argue that the patient probably would have been saved from a second morbid surgery now that he's older and more medical issues if I had done an initial lymph node dissection. However, again, it's unclear what the impact of that would be. Here's another patient. This patient has a locally advanced tumor involving their right kidney with metastatic disease. And the role of lymph node dissection in the setting of metastatic disease is completely uncharted waters. But we performed a cytoreductive nephrectomy, removed the kidney, removed multiple lymph nodes associated with the kidney, and postoperatively the patient came back, and if you can see all this sort of gray material surrounding the liver, this is the liver here, this is the stomach, this is all fluid. It's called chylous ascites, and basically what it means is that when we did our lymph node dissection, we tried to do a good job of clipping all the lymphatics that we cut, but we didn't clip them all, and so lymphatic fluid was leaking into the abdomen. And this patient required a drain placement. She had to go on a no-fat diet and had to get intravenous feeding to try and stop that lymphatic flow. And as a consequence, she couldn't go on to get chemotherapy that she required for her metastatic disease. So I would argue she definitely didn't benefit from a lymph node dissection and actually probably was harmed by it. So many urologists look to the guidelines, and we all talk about guidelines as ways that we can sort of better gauge our behavior in the clinic. So these are data from the European Urology Association, where basically they recommend that lymph node dissection should be performed on everybody. Now, I think that this is probably overkill. There clearly are patients who are not going to derive benefit from lymph node dissection. I'm really not sure what the benefit is in the metastatic setting. I think in patients who have clinically positive nodes, aggressive resection is probably warranted. I also think in the setting of locally advanced disease that doing a lymph node dissection to better enhance staging and potentially cure some patients who harbor micrometastatic disease is probably warranted. However, I really don't see the benefit in lower stage disease such as T1 and T2. So the role of lymph node dissection in locally advanced disease remains undefined. The evidence for improved cure rates with lymph node dissection is lacking. We don't have any data to suggest that even if patients have positive lymph nodes, that taking that disease out is going to make them live longer or do better. People argue that improved staging in locally advanced disease is really the only argument to do a lymph node dissection, but that somehow implies that if we know that the patient has a more advanced stage, that we can do something to change their outcome. And as I told you, we have no therapies that we know of that will do that. The benefit of lymph node dissection with clinically negative nodes in the setting of metastatic disease is completely uncharted waters and really needs to be evaluated in the context of a clinical trial. I think the overall message is that we need to do a better clinical trial that specifically asks the question of what is the role of lymph node dissection in the setting of advanced disease. And until that trial is done, really there is no guidance with regards to whether or not we should be doing lymph node dissection in patients who present with locally advanced kidney cancer. So I want to move on and talk a little bit about the management of venous tumor thrombi, which is something that many people feel is unique to kidney cancer. It's actually not. but it is a common finding happening in about 15% of patients who present with locally advanced kidney tumors. So here's a classic example. This is a patient of mine who has a locally advanced tumor involving their right kidney. It seems to me I've shown you, every single patient I've shown you today has had a tumor involving their right kidney. It does actually occur on the left as well. I'm not sure why they're all right. And here you can see there's a tumor thrombus extending up into the vena cava and actually extends all the way up into the heart. And here you can see tumors sitting in the right atrium of the heart without metastatic disease. And this patient actually underwent surgery and was cured after her surgery. So venous tumor thrombi occur most often with patients who present with clear cell renal cell carcinoma, but actually can occur with all different types of kidney cancer, and actually can occur with a variety of other non-renal retroperitoneal tumors, such as urothelial carcinoma, adrenal tumors, Wilms tumor, which is another tumor of the kidney, as well as metastases. And actually, this was a patient who presented with testicular cancer who had a venous tumor thrombus. So it happens, as I said, approximately 15% of cases of patients with kidney cancer. Actual just renal vein involvement is fairly common. It happens in about a third of patients, but more extensive involvement involving the vena cava or atrial extension is much more rare. These are the different symptoms that patients can present with when they have venous tumor involvement, and it's remarkable that almost 20% of patients actually have no symptoms, despite having extensive involvement of the venous system. With regards to evaluation, MRI is the gold standard. However, with multi-detector CTs, the sensitivity has increased dramatically, but most people still prefer an MRI for evaluating venous tumor thrombus involvement because of the lots of additional information it can provide. So here's a typical case of a patient who has, again, a right-sided tumor with a venous tumor thrombus extending up to almost the retrohepatic vena cava, but you can also see evidence of bland thrombus, meaning just blood clot, involving the lower vena cava. You can see evidence of venous collaterals. So MRI is actually very good for better staging IVC thrombi and looking for evidence of bland tumor thrombus, and again allows for better surgical planning when you take these patients to the operating room. It's important to get updated imaging. I try to get imaging on patients within a week of surgery because the thrombus can progress rapidly. You can take a patient who you believe has a level 2 thrombus to the operating room, and then when you get in there, find out that the tumor thrombus has grown dramatically and changes the complexity of the operation. Most of these patients will start on anticoagulation to prevent them from having pulmonary emboli and improve blood flow. There's such a thing as called an IVC filter, which is basically a screen that you can put into the vena cava to prevent blood clot migration. Many people will put them in for these venous tumor thrombi. However, it changes the complexity of the operation to remove the venous tumor thrombus dramatically. So I would encourage no IVC filters should be placed preoperatively. Again, these all relate to surgical planning. If there's evidence of venous wall involvement, then we would want our cardiovascular surgeons to be available to help potentially reconstruct the vena cava. And this is a retrospective study that demonstrated that the diameter of the vena cava and the renal vein helped to predict whether or not the vena cava wall is actually invaded by the tumor. There are a variety of different staging systems out there, and what this basically allows us to do is make sure that we're all speaking the same language when we're talking about venous tumor thrombi, when we talk about a level 0 versus a level 1 versus a 2, 3, or 4, that we're all speaking about the same level of involvement of the vena cava, and this one from the Mayo Clinic is the most common staging system that's used out there. So just step by step, how do we take these things out? This probably is one of the most complex operations that urologists do. First and foremost, make sure that you have a very experienced team assembled that includes liver surgeons, vascular surgeons, as well as the urologist. This is primarily a vascular operation, not a cancer operation, and it's important that you operate on the vessels first to try and get the tumor thrombus out before removing the kidney. So basically, you ligate the renal artery to cut up blood flow to the kidney and to the tumor thrombus, isolate venous structures, remove the thrombus, remove any distal bland thrombus, fix the vena cava, and then actually perform the nephrectomy to get out the cancer and perform a lymph node dissection. So these are a variety of different scenarios. I won't belabor this, but basically for a free-floating tumor thrombi, the operation is very straightforward. You just basically make an incision at the level of the renal vein, extract the thrombus, and then close it. For patients who have evidence of blood clot distally in their lower extremities, you can put in this vena cava filter here to prevent migration of this tumor thrombus and prevent pulmonary emboli. In patients who have actually clotted off their vena cava because of a low flow state related to this tumor thrombus plugging up the vena cava, you can either staple or even transect the vena cava to prevent harm from this bland thrombus migrating and causing a pulmonary embolus, but these are thankfully exceedingly rare. So again, just highlighting, this is primarily a vascular operation. So this is a patient with a venous tumor thrombus, and the first thing that we did was place ties on the renal artery to cut off blood flow to the tumor as well as to the tumor thrombus, and then worked on the vena cava to extract the tumor thrombus. So these are some cartoons that hopefully will show it more graphically for you. So this is a patient with a level 1 or level 2 thrombus. You can see the tumor thrombus here. And basically it's, like plumbing. Basically you get control above, you get control below, you control the contralateral renal vein, and then you incise the os, extract the thrombus, and then just close the cavotomy. It gets a little more complex with more advanced tumor thrombi. Here we had to mobilize the liver to allow us to get higher on the vena cava to extract the tumor thrombus. Oftentimes we'll use something called transesophageal echocardiography. So basically it's an ultrasound that passes down the throat into the esophagus to allow us to monitor the height of the thrombus and look for evidence of migration of the thrombus on real time. In terms of level 4, which means tumors that extend up into the heart, they talk about veno-veno bypass, something I've never used before, but we have used cardiopulmonary bypass, where you open up the chest and put the patient on cardiopulmonary bypass and stop the heart to allow us to extract the tumor thrombus from the heart and then restart the heart after the tumor thrombus has been extracted and the vena cava repaired. And even though this tumor thrombus is extending all the way up into the heart, these patients still can be cured. Approximately 50 to 60% of patients who present like that will be cured at 5 years out from surgery. This slide just talks briefly about the devastating complication of pulmonary embolism. So during the course of the surgery, as we're moving things around to try and take out the kidney and take out the tumor thrombus, a vast minority of patients will actually have migration of that tumor thrombus up into the lungs. I've seen it happen twice. It's quite dramatic. And the patient could actually die on the table as a consequence of this. But in this particular series of patients, they reviewed 9 cases where the patient had embolized their tumor thrombus. They were put on cardiopulmonary bypass. Hypothermic arrest was used in 4 of the patients, and you can see the outcomes. The overwhelming majority of patients did die of kidney cancer. However, a significant number of patients were alive and had no evidence of disease. So even though the tumor is involving the venous system, it doesn't mean that it's metastatic, and it doesn't mean that the patient's destined to die from metastatic kidney cancer. These are data from our institution where we again looked at the role of surgery in patients who presented with pulmonary emboli and noted that those patients who had pulmonary emboli had a very similar outcome to patients who presented without pulmonary emboli, suggesting that the embolus was not necessarily tumor and possibly could be bland thrombus. So what about the role of the robot? Dr. Mateen talked about the role of the robot in patients who presented with small renal masses. What about in these patients who present with locally advanced disease? Well, there is literature out there, although it's very small amount of cases. Here's a patient who has a locally advanced tumor involving the right kidney with an IVC thrombus. You can see they put a vessel loop around the renal vein. They opened up the vena cava. Here's the tumor thrombus here. You can see it better here. And they extracted the tumor thrombus and then sewed up the vena cava. So I think in highly select cases, it is possible to use the robot to treat these patients, but I would argue the vast majority of patients are ultimately destined to be treated with open surgery. Here's another case published by the same author, where he had a locally advanced tumor involving the kidney with a venous tumor thrombus that extended down into one of the branches of the renal vein. And this patient underwent a partial nephrectomy with the venous tumor thrombus extraction done robotically. Again, highly select, should be done by surgeons who have a lot of experience working with the robot, but I would argue the vast majority of cases are likely going to be treated with open surgery. And here, this was a retrospective review of inferior vena cava tumor thrombus surgery done robotically. And you'll note that this was published in 2014. Only 9 robotic cases had been published in the literature. So this just looks at outcomes. We looked at our experience with patients who presented with IVC tumor thrombi. We had 605 patients over a number of years. Median age was 60. Follow-up was 2 years. You can see the vast majority had just renal vein involvement, although a significant percentage did have evidence of involvement of the vena cava. 45% of patients presented without evidence of metastatic disease. The median blood loss was almost a liter. These are very bloody operations. There was a 25% complication rate within the first 30 days. And if you had no evidence of metastatic disease, your outcome was quite good. The overall survival was more than 5 years. However, patients who presented with nodal or distant metastases, their outcome was significantly worse related to their metastatic disease. 12 patients died as a consequence of surgery. There was 1 intraoperative death and then 10 who died within 30 days of surgery, and 1 patient who had a massive PE approximately 3 months out from surgery. So the point is that the surgery, despite being very complex and major, is safe. So we looked at a variety of different variables to predict outcome. They're listed here. Bottom line is we found that patients who had clear cell histology had a better outcome than those that did not. Patients who had high-grade disease or sarcomatoid dedifferentiation, evidence of fat invasion, nodal metastases or distant metastases, all of those factors were associated with a worse outcome in patients who had IVC tumor thrombi. We noted that patients who had tumor thrombi that extended up into the heart had a worse outcome than patients who just had involvement of the vena cava below the level of the diaphragm. And in comparing our series to other series that have been published in the literature in the past, outcomes are very similar. I'm going to pass through that. This was looking at a finding that was really sort of surprising to me. We looked at 270 patients who had venous tumor involvement, and we noted that almost 20% of patients had cancer present at the margin. And positive margins were more likely in patients who had a higher level tumor thrombus or those that had a higher grade tumor. And so I looked at this data and I said, wow, maybe we should do something to change our technique if more than almost 20% of patients had cancer present at the margin of resection. And those patients were more likely to have a local recurrence and more likely to have metastatic progression. So my thought was, well, maybe we should change our operative technique and check margins at the time of surgery. In those patients that had positive margins, maybe we should, resect more of the vena cava, or maybe even resect the entire vena cava and reconstruct it. But in fact, if you actually look at how these patients recur, the overwhelming majority of patients who had positive vein margins, in the blue here, progress with metastatic disease. And this would argue that changing the surgical technique or being more aggressive locally is not going to impact their outcome overall, because the vast majority are destined to progress with metastatic disease, suggesting that this is a reflection of the biology of the tumor, not some inadequacies in the surgical technique. Okay, I'm going to skip over this because it's not relevant. So suppose we don't operate on these patients. And in many cases, urologists out in the community are quite daunted by the prospect of taking one of these patients to the operating room because of the complex nature of the surgery. Well, this was a retrospective study looking at conservative management of patients who present with IVC tumor thrombi, and you can see that patients that are not operated on do poorly. Systemic therapy alone does not work in these patients. This was a study out of the Mayo Clinic that showed this exact same thing. So what about the role of systemic therapy in the treatment of these tumors? Many times patients out in the community will be started on some form of targeted therapy and told that this targeted therapy will make your tumor thrombus shrink and make your surgery easier. And there are multiple anecdotes in the literature suggesting that starting patients on targeted therapy will dramatically reduce the size of their tumor thrombus. We published a retrospective study looking at the role of targeted therapy in shrinking tumor thrombi. Long story short, the bottom line is the vast majority of patients had little to no impact on their tumor thrombus as a consequence of systemic therapy. There were 3 patients that did have some decrease in the level of their tumor thrombus, but the vast majority had little to no impact. We did another study where we looked at patients with metastatic disease treated with targeted therapy. We had 48 patients who had venous involvement, and again, the very similar story that the vast majority of cases had little to no impact on their tumor thrombus as a consequence of being treated with targeted therapy. You can see 75% had stable disease, and in fact, 15% of patients actually grew while they were getting the targeted therapy. So I would argue that there's little to no benefit from systemic therapy in treating patients who present with venous tumor thrombi, and that surgical therapy remains the gold standard. Then lastly, I'm going to talk about one of the devastating complications associated with the venous tumor thrombi, and that's Budd-Chiari syndrome. So basically, if the tumor thrombus grows big enough, it can grow past the hepatic veins and actually cut off blood flow draining from the liver. And you can see this sort of flow defect in the liver that's consistent with a Budd-Chiari syndrome. And patients will present with abdominal pain. They'll have ascites, which means fluid in the abdomen. You can see there's fluid in the abdomen over here. Hepatomegaly, meaning enlargement of the liver, lower extremity edema, and abnormalities in their liver function tests. In our hands, if patients present with this syndrome and we take them to the operating room, the in-hospital mortality rate is in excess of 80%. So basically, the overwhelming majority of these patients, if you try to operate on them, will die. So what we do now, instead of taking them to the operating room, is we will embolize the kidney, meaning to cut off blood flow to the kidney in the hopes that this vascular thrombus will shrink as it did here. And you can see that there's shrinkage of the tumor thrombus. There's blood flow occurring in the vena cava around the tumor thrombus. You no longer see that perfusion defect in the liver. And after 3 months of allowing this tumor thrombus to shrink, we were able to take this patient to the operating room and cure them of their kidney cancer. So radical nephrectomy with IVC thrombectomy is a very demanding surgery that can be associated with significant side effects and mortality. But in the absence of metastases or nodal disease or sarcomatoid dedifferentiation or fat involvement, it does appear to be associated with an excellent prognosis. Minimally invasive approaches are described, but I would argue is not the standard of care, and patient selection appears to be critical in terms of better selecting patients for minimally invasive approaches. And pre-surgical treatment with either embolization or targeted agents does not appear to be helpful and in fact may worsen a patient's prognosis. So that's basically a sort of summary of how to treat patients who present with locally advanced disease. Again, the take-home points are adjuvant therapy does not exist in 2016. The role of lymph node dissection is unknown, but in locally advanced disease it's probably advocated. And the management of IVC thrombi can be quite challenging, but patients will still have excellent outcomes as long as they're treated at major centers by people who have experience. So now, I don't have my agenda. Is it? Oh, okay. So Dr. Karam now is going to talk about the management of patients, surgical management of patients who present with metastatic disease with their primary tumor in place, looking at whether or not there's a role for removal of the kidney in the setting of metastatic disease, and also looking at the role of metastasectomy.
Want your coffee bowl? Okay. Good morning, everyone. I would like to thank the Kidney Cancer Association and Dr. Wood for inviting me to be here today. It's my pleasure to be here and give this presentation and talk to you all after the presentation as well. So my job today is to talk to you about the role of surgery in patients who already have metastatic disease, whether it's surgery to remove the kidney or to remove the metastatic areas as well. Just to make sure I stay on time. So just to give a few definitions, metastatic kidney cancer means that the kidney has spread outside of the tumor has spread outside of the kidney, and it's also known as stage 4 kidney cancer. And when we talk about cytoreductive nephrectomy, we mean removing the kidney in a patient who has metastatic disease. So this is called cytoreductive nephrectomy. And when we talk about metastasectomy, this means removal of a metastasis, which is removal of an area of tumor spread outside of the kidney in a patient who has this issue, which is stage 4 kidney cancer. So the first part of the talk will be cytoreductive nephrectomy, again removing the kidney itself in patients with stage 4 kidney cancer. These are the recommendations from the European Association. As you can see here, for stage 4, they simply recommend that in selected patients, we should do the surgery. As you can tell, this is not very helpful for individual patients. And through the talk, I'll tell you what the nuances are when we try to select patients for this type of an operation. These are from the National Comprehensive Cancer Network guidelines. And this is what they say. So if you have a primary tumor, meaning a kidney tumor that's removable by surgery, and an area of metastasis that's just one area that is removable as well, then this patient should have both the cytoreductive nephrectomy and the metastasectomy. Now, they don't have to happen at the same time, but both should be recommended. Now, if the patient has a kidney tumor that's removable by surgery, but they have multiple areas of spread, the recommendation in this situation is to do the actual surgery to remove the kidney itself and then give systemic therapy or medications either by mouth or by vein. And my colleagues from medical oncology will discuss that in the second part of the session today. Now, if the patient has a tumor that cannot be removed by surgery, or if the patient is not fit enough to undergo an operation, then this patient should, in general, not have surgery and just receive medical therapy. And this is a more reasonable guideline compared to the European one at this point. So we do have data on cytoreductive nephrectomy in what we call the immunotherapy era. This is the era when our colleagues used to use interferon therapy or interleukin therapy. They are used now, but definitely to a much lesser extent. And on these types of curves, and you'll see a lot of them today, the higher the curve is, which you see it up here, that means a better outcome in general. So here you could see that we're talking about survival, and if you do a nephrectomy plus the medical therapy, the survival is better because the curve is higher than just giving medical therapy alone without kidney removal. This was a randomized clinical trial, so this is the best level of evidence that we have, and this was mostly based in the United States, but this was published about 15 years ago. In the same year, a similar study was done in Europe, and this is led by our German colleagues, and again, the same concept that you see here. So the higher the curve, the better the outcome, and this is for the study group, which means the patients that had both the surgery and the medical therapy, compared to the patients who had just the medical therapy alone. And again, this is a randomized prospective trial. Now, when the authors combined the results of both studies, they found the same result, basically, that if you combine surgery plus therapy, you have a better outcome than just having the therapy alone without surgery. But again, you have to keep in mind that these patients that were entered into these clinical trials had to meet very strict selection criteria. So this is not just any patient that had metastatic disease. These patients were very well selected based on very specific criteria. Now, this is a subsequent study, and this was retrospective, but they used the same selection criteria, but instead of using interferon therapy, they used interleukin-2 therapy, which is felt to be more aggressive, but also more curative. And as you can see here, this is interferon alone, the lowest curve, so this is the worst outcome. Surgery plus interferon is better, but when you combine surgery plus interleukin, it's the best compared to the other therapies. Now, these drugs, as I mentioned earlier, are not given as frequently anymore. So now we live in what people term the targeted therapy era. These are drugs that some of you may have heard of or might have even used. And we don't have any finished clinical trials to tell us what we should do. But we have 2 ongoing clinical trials. One of them is called Carmina, and it's based mostly in Europe. And what they're doing is that they're randomizing, meaning they take the patient, and by random, the patient either receives the surgery, nephrectomy, followed by a drug called sunitinib, or they receive just the drug itself without an operation. The primary objective is to compare the survival in both patient groups. And this trial is slowly accruing, and it's been accruing for quite some time now. Now, a different study, also mostly based in Europe, called the Surtime trial. As you can see here, both groups received the surgery. One group had surgery followed by the medication. The other group had the medication for some time, then surgery, and then went back on the medication afterwards. Again, this study is still accruing, so both of these studies, we don't have the results just yet. So in the meantime, what are we supposed to do as doctors? We live in the targeted therapy era, but we don't have any hard evidence based on prospective or large randomized trial to tell us what we should do. So in the meantime, we're basing our practice on mostly retrospective studies, and I'll show you some here. So these are in patients who had nephrectomy. We see that the response rates to therapies appear to be better than patients who did not have nephrectomy. Again, this is retrospective data. Again, going back to the same types of curves, we see that outcomes in general are better in patients who had surgery compared to those who did not have surgery. And you see that for both the progression-free survival and in overall survival as well. These are other studies that I'm just going to go through, different studies all showing the same thing. but keep in mind they're all retrospective, meaning they're not actual clinical trials. Again, the red line is for patients who had surgery, their survival is better. Yet another study, if they've had surgery, the survival appears to be better. However, we know that universally this doesn't apply. So not every single patient that had received surgery has experienced an improved in survival or in outcomes. So how do we really select these patients? And how do we know who to recommend surgery for? So we know there are several factors that in general we look at when we see a patient in clinic. One thing we look at is tumor burden, meaning how much tumor does this patient have, both in the kidney and also outside of the kidney as well. And this makes sense. The more tumor we can remove with surgery, the better outcome the patient will have. And these are just different cut points that have been published. So if you remove more than 95% of the tumor, it makes sense that the patient will do better than if you remove just 5% or 10% of the tumor. Another factor we look at is the stage of the disease. Now, we're talking about patients with stage 4 kidney cancer, but this particular slide, I'm talking about the stage of the actual tumor itself, meaning how aggressive or how large the tumor is in the kidney itself. And we know for tumors that are very aggressive, that are invading other organs, the outcomes in these patients are not very good if they have metastatic disease already. So in general, we try not to do surgery for this particular group of patients, which actually is rare. Now, histology, meaning what is the type of kidney cancer? As you might know, kidney cancer is not just one disease, there's different types. Clear cell is the most common type, and the other types we can lump them together in one group called non-clear cell histologies. And this makes up about 20% or so of the patients. The data on this are at this point conflicting. There are some studies that say if you do cytoreductive nephrectomy in patients with non-clear cell, the outcomes are better, and there are some studies that say the outcomes are not different. So we are looking at our database currently to revisit this topic to see if we can find out who benefits from this surgery if they have non-clear cell histology. There are also factors that are hospital-based. So this is from a very large database called the National Inpatient Sample that looked at more than 16,000 patients who had cytoreductive nephrectomy, and they found that outcomes are worse if the patients are older, and I'll visit that in a second. The outcomes are worse if the patients are not healthy, which also makes sense. They're worse in smaller hospitals, meaning that the hospital that does not do this type of surgery very frequently. And obviously the outcomes are worse and survival is worse if the patient has complications after surgery. Now, going to age, these are two studies. One of them is from our institution here that found that in general, if patients are over 75 years of age and have cytoreductive nephrectomy, they are at a higher risk of complications and even a higher risk of mortality or dying after surgery. Again, we're talking a small percentage, 5% in patients older than 75, but this number is larger than in those who are less than 75 years of age. So it's important to keep age in mind as well. Now, one study that we did here several years ago to try to identify who might benefit from this type of operation. So we looked at our databases, and this is retrospective, and try to compare survival in patients who had surgery and in patients who did not have surgery. And again, as we note here, that patients who had surgery did better. However, you have to think that if they did not have surgery here, that means that there's a very good reason why they did not have it. Either they had too much spread outside of the kidney, or the patients were too old or too unhealthy to have an operation. And we found that there's these 7 factors that can predict who might benefit from surgery. And when we look at these factors together, we found that if the patient has 3 or less risk factors, they do better than patients who have 4 or more risk factors here. And again, you see the same type of curve. If a patient has 3 or less of these risk factors, they do better than the other group of patients. And the other group of patients is either patients who did not have surgery, and you can see here that the survival is very similar to those patients who had surgery but had 4 or more of these risk factors. So in general, if the patient has 4 or more of these risk factors, we tend not to offer surgery. But again, it's a little bit more complicated even than that. And A similar study was done by a different collaboration from multiple institutions in multiple countries, and they found similar findings. Basically, if you have 3 or less risk factors, and these are slightly different risk factors than the ones we found, the survival is better than if you have 4 or more of these risk factors. When we talk about cytoreductive nephrectomy, it doesn't always have to be through a large open incision. In selected patients, we can offer a laparoscopic cytoreductive nephrectomy that could offer patients less blood loss, a shorter stay in the hospital, and shorter recovery time, and even quicker start of therapy after the operation. So whenever we can do this operation laparoscopically, we tend to do it this way. But again, this has to be in well-selected patients. And in a very small percentage of patients, we don't even have to remove the entire kidney, and we can remove only a portion of the kidney. But this is something that's done very rarely, but it can be done in very selected patients. Now, having told you, that there are benefits for surgery, that surgery is important, there are some arguments against surgery that we should all be aware of. Surgery does have some morbidity, it has some side effects that we always inform the patients about when we do the surgery or before we do the surgery. Again, the only benefit that we know of from large prospective studies comes in the area of immunotherapy, especially with interferon. Sometimes patients can spend a long time recovering from an operation, and sometimes the patient can have disease progression after surgery, meaning that the tumor that's outside of the kidney that we did not remove can grow fast sometimes after surgery. Not necessarily because of the surgery itself, but that's how the tumor was meant to behave. And in the few weeks after surgery, we can't really start the patients on medications because we're afraid of complications from the medications, such as wound healing issues and things like that. So we still have some work to do. We need to still better identify patients who might benefit from this type of operation. That's the operation to remove the kidney and stage 4 conditions. And we also have to find out the correct sequencing, whether we should give medications first and then do surgery, or whether we should do the surgery and then give medications to treat the cancer. And we're still trying to find ways to improve on the surgical techniques and use minimally invasive surgery whenever it's reasonable to do so to improve the quality of life of patients after an operation. So just take-home messages from the first portion of the talk. That we're still awaiting the ongoing trials, and these trials are being done with targeted therapies. We don't have the results just yet. I think surgery still is an important part of a multidisciplinary plan in patients who have metastatic disease. And surgery is still recommended in patients who are young, in patients who have clear cell histology, who have good performance status, meaning they're behaving as normal as possible, they don't feel very tired, they're not very sick, they're not in bed all day because they're very tired. It's also important to do the surgery or to consider it in patients who have limited disease outside of the kidney and patients who have a limited number of poor risk factors that I mentioned, 3 or less risk factors. And it's preferable to do it in high volume centers just because of the experience of the entire institution, the surgeon, the anesthesiologist, and other surgeons that could assist with the operation as well. However, just because a patient does not fall in one of these categories doesn't mean that they are automatically disqualified from having surgery. Again, we have to look at each patient individually and decide with the patient what we think is the best way to proceed. So these are just more of recommendations and suggestions, but if the patient does not fall in this category, they can still be considered for surgery if appropriate. This is some work that we've done from our institution for further reading if you're interested. And I'm going to move on quickly to the second part, and this will be shorter than the first one, and this is on metastasectomy. So the first part, we tackled removing the kidney itself in a patient with stage 4. Now we're talking about removing the actual spread, whether it's in the lung or the liver or other areas, and I'll go through this briefly. So there are some challenges in this setting. In patients who have metastatic kidney cancer, we know that most of the kidney cancers are not responsive to traditional chemotherapy. We know they're not very responsive to most radiation therapy. And the cytokine therapy, that's the interferon and the interleukin that I mentioned earlier, most patients do not respond. Only a small minority of patients respond to this. And with the targeted therapies that are currently being used mostly, there are rare complete responses, meaning that it's rare to give this medication and see that all the tumor has disappeared. We see very good responses, meaning the tumors are shrinking, they're not growing as fast, but it's rare to see that all the tumors disappeared with these types of medications. So there are other options in very well selected patients, and you'll hear me say a lot. So not every patient who has spread outside of the kidney is a candidate for surgery to remove that spread. Sometimes there's multiple areas that cannot be removed by surgery. Sometimes technically it's not doable to do the surgery safely and cure the cancer that way. But surgery is an option in a group of patients. And these are the guidelines. These are similar guidelines that I showed you earlier. This is from the European Association of Urology, and basically this is what they recommend, that no general recommendations can be made. If we had very specific recommendations, you probably don't need to listen to me this morning giving this talk. I will show just one slide and step down. But the reason we're doing this talk is because it's a dialogue, and it's not set in stone what we should or should not do for our patients with metastatic disease. So let's talk a little bit about survival in patients who have metastatic disease that have underwent metastasectomy. This is one of the earliest studies from our colleagues from Memorial Sloan Kettering, almost 300 patients, and this includes patients who had a complete metastasectomy, meaning they already had their kidney removed, they had metastasis, and these metastases were surgically removed. And in this very select group of patients, the 5-year survival was about 44%, which is pretty good. But again, this is a small group of patients and not all the patients who presented to the hospital with metastatic disease. And it's important to keep that in mind. And what you'll see is a very similar number throughout the studies that I'm going to show you. This is another study, also 5-year survival if the patient has had any type of metastasectomy, about 49%. This is a much larger study. Again, the survival is about 44%, again, in those patients who had metastasectomy. This is the total number of patients. This is not the number of patients who had metastasectomy. And this is one of the most recent studies from Mayo Clinic, almost 900 patients. Again, not all of them had surgery. Less than 20% had metastasectomy. But in those patients who had complete metastasectomy, the 5-year survival was about 45%, which is actually quite good. And this is the study that I just referenced to you. Again, this is from our colleagues from the Mayo Clinic. This was over a 30-year period. This is a retrospective study, and only 14% of these patients had complete metastasectomy, meaning they had complete surgical removal of any disease outside of the kidney. And I looked at the impact of surgery based on different factors. I'll just show you a few of them here. So in patients who had complete surgical resection, the survival was about 5 years compared to those patients who had no complete resection, and that's only about 1 year. So we see some separation of the curves. Again, the higher the curve, the better the survival is. And in patients who had only spread into the lungs, if we can remove all that surgically, the survival is definitely better than if we cannot do so. And this was also true for disease that's outside of the lungs. And you could see also improved survival in patients who had complete surgical removal versus not. Again, keep in mind this is also retrospective. And this makes sense. If we can remove all the spread outside of the kidney, the outcomes are better than if we can remove some of the spread, and the outcome is better than if none of the spread has been removed. But again, keep in mind that if a patient did not have this type of an operation, there must have been a good reason why they did not have it. Again, maybe they're old, maybe they're not very healthy, maybe they have too much spread outside of the kidney that it doesn't make sense to go after each area of spread. And this is what we call a systematic review. So this group of authors looked at multiple manuscripts from the literature, and they put those all together in a big table, and they studied what are the effects. So what they found is that you see here the black box, and in all of these studies, there seemed to be a trend that metastasectomy can improve survival. Again, all these studies here are retrospective studies. None of them are true prospective studies. There are specific metastatic sites that usually kidney cancer likes to go to. Brain is one, although it's not very common. Thyroid is very uncommon. Lung is the most common one. There's also liver, pancreas. Pancreas typically happens several years after initial diagnosis in majority of cases. that do have pancreatic spread, but also it's quite uncommon. So the majority of spread, we see it in the lung, liver, and the lymph nodes. And then surgery or radiation can be done for these tumor areas. For example, for brain, surgery can be done if necessary. We can do radiation for the entire brain if there are multiple areas, or you can do what we call stereotactic radiotherapy or gamma knife to attack one or two spots in the brain. Typically, if there's a spread into the thyroid gland, surgically is done for this. For the lung, if there is a few spots on the lung that are removable by surgery, and that's the only area of spread, that's something that can be done as well. For liver, in general, we try not to do metastasectomies just because, in general, liver spread is a poor prognostic factor, meaning that we don't know for sure that if we do the surgery that we're going to actually help the patient. So we don't really have that much data on removing spread from the liver in patients with metastatic disease of the kidney itself. For pancreas, we can remove part of the pancreas. We can remove the entire pancreas depending on where the tumor is, and this is typically done by our colleagues from general surgery. And in general, the patients do relatively well after this type of surgery. Again, partially because spread to the pancreas happens late after the initial diagnosis. We recently published our work on doing surgery for areas of spreading into the adrenal glands, into the lymph nodes close to the kidney, or in the area where the kidney used to be before. And we found that if that's the only area of spread, doing surgery can cure up to 40% of patients without any additional therapy. So again, it doesn't cure 100% of patients, but it cures almost half the patients if we select those patients very well. Of course, kidney cancer can also go to the bone, and surgery on the bone can be done for different reasons, either because the bone has already broken, or because the bone is about to break, or because the patient is having a lot of pain. So either surgery and or radiation therapy can be done in those particular scenarios. We can also integrate surgery with systemic therapy, meaning either we can give immunotherapy beforehand, and this is a manuscript published by our colleagues from medical oncology, 38 patients who received immunotherapy and then had metastasectomy, and about 76% had complete resection of all their metastatic disease, and it took about 2 years before their disease started to progress, which is good, and the survival was about 5 years in this patient group. This is another study that was published with targeted therapy and not immune therapy. Again, a small study, and these patients received targeted therapy and then had metastasectomy. And the survival in this study, we found that 21 patients out of the 22 were still alive at about 2 years after this type of an operation. All it shows is it's feasible, but this is not the standard of care. There are studies also that either give the patients a placebo or a sugar pill after complete removal of metastatic disease, or give them a medication. You have here different types of medication. The one that the clinical trial that's active in the US is this one, using a drug pazopanib. So what happens is that a patient has had a nephrectomy, then they develop spread, for example, into the lung, then they have the lung spread removed by surgery, and now on CT scan, there's no evidence of cancer anywhere. So these patients, if they go into this trial, they either receive a sugar pill or they receive pazopanib to try to see if this drug helps. But just like Dr. Wood just mentioned, in patients without metastatic disease, that this type of study did not show any benefit. However, this has not been done in patients with metastatic disease, so it's worthwhile waiting to see what the outcomes will be. We definitely need to do more research to see how we time the surgery in patients who present with disease spread when they are diagnosed initially, or if they have the cancer spread a few years after the initial diagnosis. We can use these targeted therapies to test which patient might benefit from metastasectomy. We are doing some research on the potential benefits or not of metastasectomy in patients who have non-clear cell histology. And it's interesting to see how many patients might benefit from the surgery but are not being offered the surgery. And we don't really have that information, again, because most of these surgeries are done in specialized centers. So take-home messages for this portion of the talk on metastasectomy. We have to keep in mind from all the data I showed you that there is a selection bias, meaning the patients who had metastacectomy had it because probably they were younger, healthier, limited disease spread outside of the kidney. And probably the patients who did not have the metastacectomy did not have it because they're maybe older, too much disease spread, or they're not healthy. However, we still believe that metastacectomy is important in selected patients. Again, these are very similar criteria to the first part of the talk I showed you for cytoreductive nephrectomy. If they have good performance status, meaning if they're as healthy as possible, if they're good surgical candidates, if they have limited disease spread outside of the kidney, if it took a long time for the cancer to spread, that's a good indicator. That's better than when a patient presents with spread at the initial diagnosis. If we can remove the entire tumor, that's a good indicator. However, we still have to do metastacectomy sometimes for palliative purposes, meaning to improve our patient's symptoms, such as doing surgery on bone or on brain, for example. However, we know we still need better tools to select our patients appropriately for this type of operation, and that's something that's being actively worked on here and other centers as well. And we still need to study further the integration of these types of surgeries with systemic therapy to see what's the best sequence for our patients. And this is another work from our institution on the role of metastacectomy for further reading if you're interested. And thank you very much for your attention this morning.
Jose, questions? So that basically is a summary of the surgical management for patients who present with localized, locally advanced, and metastatic kidney cancer. Does anyone have any questions? Sir?
Dr. Mateen had mentioned talking about getting scanned and how you use protocols here that help to pick up better images. And I live quite a distance away, so I get my scans done somewhere else. Is there some way that I can kind of let the folks that do my scans understand what those protocols might be to get better image quality, to catch things earlier?
So just to repeat the question for the video, one of the audience members is asking if the quality or if the sensitivity of the scans done, say, here in a major medical center are different from those done out in the community, and is there anything that can be done to sort of improve the quality and sensitivity of the scans done in the community to detect disease recurrence earlier with the potential that it may be more curable if it's found earlier?
Yeah, it's a good question. The fact is there's really no method for us to tell another doctor how to do their job. And so the fact is in the community we do see some good scans. And so, some places understand why they're doing the test. They're given a requisition that asks for a CT scan of the abdomen to be done, for example, in a patient with treated kidney cancer. And so the radiologist knows what to look for, and they may protocol it appropriately. So it depends on multiple levels of things that happen up to that point, how much information they're given, if they know what it's being done for, and then also how they actually do the test. And so we do get good scans from the community. I'm not saying we only do the best. That's not the case at all. But we do see a wide variety of quality of scans from the outside. In your particular case, if you haven't heard of problems from when you're getting scans from the outside, then it sounds like it's probably fine. And then when we do scans for follow-up in terms of surveillance, it is a little different than when we're looking at first to assess the tumor in the kidney and how we're going to address it. Actually, that scan arguably uses more radiation, is a little more complicated, because basically they do almost 4 different phases: before contrast, early contrast, medium range into and then late contrast phase. When we were doing it for follow-up, we don't need all that. And so, again, those are some of the details. And again, most radiologists who, if they're told why it's being done, and of course that depends on who's ordering the test, then they'll know usually how to protocol it appropriately. But again, depending on where these things are. Sometimes it's a one-size-fits-all approach, and then some others are more specific. Is that too complicated of an answer?
Pretty long-winded. Jose?
So the other thing is what we do here, in addition to the radiologist doing the test and reading it, in our practice as urologists here, Dr. Wood, Dr. Mateen, and I, we all look at the images ourselves as well. So that's also a very important point, not just going simply by the radiology report and what it says, but also physically in our clinic we look at the images ourselves just to make sure that this is the case.
And it's a team approach, you know. Sometimes they miss things. They're human. Sometimes we miss things, and we rely on the radio. You know, I don't look at the bones. Not great at looking at the liver and the lung, and so I count on the radiologist to catch those things. But I do know that I'm not likely to miss anything in the kidney, excuse me. And so, you know, I think with that, it's a team approach. And what we encounter a lot of times are patients who have scans, and I suspect a lot of times it's just the report that's being read, because you can easily look at the scan and realize that either there really is no problem or that there was a problem and no one really picked up on it. And we see that all the time.
Question?
I'm wondering, are there genetic markers that may help with diagnosis and perhaps direct management of renal cancer?
So the question from the audience is, are there genetic markers that can be used to better understand and treat kidney cancer and perhaps improve prognosis? Sorry, you want to tackle that?
No, Jose will do it.
The short answer is, at this point, no. There are some markers that we use to help differentiate the diagnosis itself. So what Dr. Mateen mentioned earlier, sometimes it's not very clear on the microscope what type of kidney cancer it is, and then you can do some additional genetic testing to try to tease that out. But in clinical practice, I don't believe we use any specific marker to tell us we should do this type of surgery or that type of surgery at present.
The only caveat to that would be that, you know, there clearly are genetic syndromes like VHL and HLRCC and other syndromes that are associated with specific genetic defects, that knowing those genetic defects can put the clinician on, you know, make him aware to look for other potential sequelae associated with that genetic syndrome. Like, for instance, in VHL, they can get vascular tumors of the brain, they can get pheochromocytomas, they can get tumors of the pancreas and so forth. So knowing that your patient has that VHL genetic defect is going to make you much more aware and looking for those other potential side effects that occur as a consequence of the syndrome. Other questions? Sir?
Yeah, I have two. Just to follow is the genetic thing. I was curious about that, and I actually had genetic testing done because I was worried, is there a genetic defect that can be passed to my children that so they maybe we should have them scanned for ultrasound when they get to a certain age or something like that. So what are your thoughts on that? And then I got a question for you.
So the question, one question from the audience is, you know, in terms of genetic forms of kidney cancer, what's the recommendations regarding, you know, what are the chances of passing it on to your children and how should they be evaluated and so forth? Dr. Mateen?
Thank you. I'm going to potentially give another long-winded answer, but it's also because I want you to understand, and this is actually a very common misunderstanding even amongst urologists and physicians, that we think that if we suspect there's something genetic going on, that we can send it to genetics counseling, and that there will be this incredible discovery, that they can look for anything. That's not the case. There are known genetic syndromes, as Chris mentioned, VHL being the predominant one with kidney cancer. And all genetics people can do is look for those specific mutations and conditions. So if I see something that occurs in a family, and I'm worried about a genetic syndrome, and we send it to them, and they say, no, this is not a case of VHL, it doesn't mean that there's no genetic syndrome. It means there's not one that we can identify, because we've only probably identified the most common ones. Although with kidney cancer, then there's the issue of common exposure. Maybe everybody in the family had it because maybe you got exposed to something along the way that predisposed you to it. We don't know. But so that's what I think we need to understand, and what I try to teach our trainees is that, you know, it's not this magic that happens when you send someone to genetic counseling. We actually have to suspect what that is. It's not like they reach into this magic box and suddenly they make a great discovery. It has to be a known defect because that's all they can really look for. I don't know if this makes sense or not, but it's not that hard of a science as people make it out to be. There has to be actually a clinical suspicion that backs it up. So having said that, to answer you much more specifically, in cases when even we get a negative genetic test, but very recently, actually, a physician that I treated, father and son had it. I suspect the genetic test will be negative because there isn't those other vascular tumors that we tend to see in that genetic syndrome. It doesn't mean there's nothing going on. And so what I tell them is, look, everybody else in your first-line descendants, any reason you can find to get an ultrasound of the kidney once, after age 25, 30, maybe once a year or every other year, get it done. There may be some issues with insurance coverage, so I don't propose CT scans and things like that for no reason. There's also radiation. So just finding a reason to get an ultrasound done by a primary care doctor every once in a while in those settings is what I recommend, even though there is no objective evidence that there's anything genetic going on. I did tell you I was going to be long-winded about it.
There was.
And I did have one more, sorry, everybody, but Dr. Wood, you had talked earlier about adjunctive therapy, and in that line, I had a question about, is there anything that we as patients could be doing or should be doing? I know that the adjunctive therapies of radiation and chemo don't work so well on the cancer, but is there anything we could be doing to help avoid recurrence or making things worse? We think about exercise or diet or weight, or certainly none of us need to be smoking, but there's not so much research out there that I can find that says you should be doing this or not doing that.
So just to reiterate the question is about adjuvant therapy, and basically, the question from the audience is there anything, lifestyle changes that can occur, that can be done that potentially can decrease the risk of recurrence of cancer? So the short answer, unfortunately, is no. I mean, from my perspective, a lot of the people always say that, do I need to change my diet? Do I need to, exercise more, lose weight, et cetera? All those things they should do, not necessarily because it's going to decrease the risk of cancer recurrence, but because it's healthy and better for them, heart health and cardiovascular health and so forth. From my perspective, although there's no direct evidence, if you've already had kidney cancer, the die has been cast. And it's hard for me to sort of believe that, if you give up steak and don't drink red wine anymore, that it's going to somehow alter that risk of having the cancer come back. So I don't usually typically advocate dramatic changes in lifestyle aside from the things that I talked about, and that is weight loss and blood pressure control, make sure that the patient stays hydrated, and things that I would advocate to anybody in this room, regardless of their status regarding kidney cancer. Do you guys agree?
Yes. I mean, the data that Dr. Mateen showed in his presentation, for patients with early-stage kidney cancer, the chance of recurrence is quite low. And then when these patients, pass away, most of them don't do that from kidney cancer. Most of them is from heart disease or other issues. So all these things that you mentioned, diet, exercise, stopping smoking, all this is just important for not necessarily cancer health, but also health in general. And we recommend them for our patients just because most of our patients early stage are cured already with surgery, but we need to make sure that they live long from the other reasons as well.
Okay, why don't we take a quick break? We'll reconvene at 11 o'clock and then start talking about the different systemic therapy options for patients with advanced disease. And then over lunch, we'll do some case presentations so that you can sort of look into the minds of these supposed experts and how they manage kidney cancer. Okay, so we're going to go ahead and get started with the second part of our conference. So as I said, you've heard basically a summary of the surgical approaches for patients who present with kidney cancer, both from the localized, locally advanced, as well as metastatic disease. And now we're going to have our medical oncologist colleagues talk to you about the different systemic therapies that are available for the treatment of kidney cancer, starting off first with targeted agents. And then Dr. Tenier will talk to you a bit about management of non-clear cell histology. And then Dr. Gao will finish up with the new exciting developments in terms of modulating the immune system to treat kidney cancer. So first, Dr. Eric Yonash, a professor from GU Medical Oncology, is going to talk to us about targeted therapies for the treatment of kidney cancer.
Thanks for the kind introduction, and thank you all for being here today. So really what I'm going to be talking about in the next 30 minutes is going to set the stage for some of the various treatments that we're going to be talking about later on in terms of the context of what targeted therapies are, and at the end, a little bit of a dovetail into Dr. Gao's talk into what they're going to be, what's going to happen with these in combination with immunotherapy, and also Dr. Tenier's talk with regards to how we use these in non-clear cell renal cell carcinoma. So I'm going to use the phrases kidney cancer, renal cell carcinoma, and RCC interchangeably throughout this talk, so they all kind of mean the same thing here. And I'll be defining subtypes of renal cell carcinoma where necessary, although most of what I'm talking about here really is clear cell renal cell carcinoma. And so, our paradigm in 2016 for how we treat renal cell carcinoma once it's spread to other organs in the body really is that we start off with a treatment A where we have good evidence that this is going to be helpful in individuals who have not received prior therapy. We then move on to treatment B in the context of what patients have received previously, and move on to hopefully treatment C and D and E as we move down the line. And how we actually sequence these is obviously an art and a science in of itself, but I'm going to talk a little bit more specifically just about the information we have about some of these agents. So we're going to break this down into what I would call anti-angiogenic agents, or for the large part TKIs, or kinase inhibitors. And these are the kinase inhibitors that have been FDA approved or about to be FDA approved in renal cell carcinoma, with a bit of a question mark here. But the ones that I'm mainly going to focus on this morning are sunitinib or Sutent, pazopanib or Votrient, axitinib or Inlyta. I'm not going to talk that much about bevacizumab or sorafenib because we don't use them quite as much, and I only have 30 minutes. And I'm going to talk about Cometriq or cabozantinib, which and also lenvatinib I'm not going to talk about for the interest of time. The other major sort of targeted drugs I'm going to talk about are these mammalian target of rapamycin or mTOR inhibitors, of which we have two that are approved, temsirolimus and everolimus. And then Dr. Gao is going to talk mainly about nivolumab and other immune therapies, and there are two FDA-approved immune therapies for renal cell carcinoma, nivolumab and high-dose interleukin-2 or IL-2. So what is targeted therapy? It's a buzzword. It's one that we use a whole lot. And it's really a fancy way of describing a drug that can block a specific function within a cell, mainly by interacting with some other molecule. If you will, antibiotics are a form of targeted therapy. They target a particular molecule within the bacterium and kill the bacterium. So are some forms of anti-cancer drugs, like receptor tyrosine kinase inhibitors, or TKIs, or the mTOR inhibitors, that we are using. So what is a kinase inhibitor, and where are the ones that we're currently using working? So what I have here is I have an image of a tumor, and when we think about treating tumors, it's really important that we realize we're treating an organ here, right? We're not, there are the cancer cells, but once you get beyond a certain number of cancer cells, those cancer cells then start developing their own ecosystem, their own organ, where they have blood vessel cells that start coming in and feeding it. They then have these stromal cells, and you also start getting immune cells that come in there as well. And this whole thing kind of interacts in ways that we're gradually learning is actually critical for us to learn, and how we actually design studies where we can actually look under the hood of how the cancer is working is critically important. So the kinase inhibitors are working on particular proteins that are on the surface of cells, and this could be on the surface here I'm pointing to an endothelial or blood vessel cell, or it could also be, or we could also have targeted therapies against something that's inside the cell that actually does work inside the cell. And so then this little this receptor actually is it's for the large part these are proteins, and the protein is basically a string of amino acids, which are the building blocks of proteins, and they form very specific shapes. And each protein, if you have a string of several hundred amino acids of one type versus a string of several hundred or 1,000 amino acids of another type, you get something that kind of clumps together in these very beautiful shapes in very different ways. And that very different shape then confers different activity. What then happens is we can then get that protein can then be regulated. Okay? So you have, let's say that this protein here is on the surface of a cell, and some kind of other molecule comes along and interacts and touches this protein, and that will then allow this protein to get modified in a way that it'll get activated. And what I have here, a little P with a circle, is a phosphorylation, which is a very common way for a protein then to get activated. And that then gets that protein to start then talking to other proteins and turning those proteins on. And what a kinase is essentially a protein that actually can activate other proteins. And so what we want to do in cancer is we want to inhibit the activation of some of these bad proteins, or these proteins that shouldn't be activated, and that's going to decrease the behavior of the cancer. And so what we have here is we have now what's called a small molecule, and the reason it's called small is relative to the protein, which is small already, but this is even smaller, as you can see by its size. It's a chemical structure now. It's not made of amino acids. It's a chemical structure that's been designed to basically fit into some of the peaks and valleys, mainly valleys, of this protein, that then jams that protein and prevents it from working. Okay, so when you take Sutent or Votrient, basically what you're taking a chemical that's been carefully designed to interact with very specific proteins that help the cancer grow. And in the case of Sutent or sunitinib and pazopanib and the other TKIs, these are usually VEGF receptors. These are receptors on the surface of the endothelial cells. So basically you're starving the endothelial cells. Clear cell renal cell carcinoma is the one that actually produces the most of these blood vessel cells that we can then target with these drugs. And so what I have here is I have the different major subtypes, and you've probably seen this already a few times this morning, and we have clear cell over on the left, which has a mutation in the VHL gene. And the VHL gene creates a protein, and again we see these cute little, things that look like something that maybe your kids or grandkids would, draw. But what they are is they're actually depictions of how these amino acids actually form shapes. And this is the one that the red is the VHL. And the VHL forms this very special protein that does stuff inside the cell. And what VHL does is it actually regulates other proteins. And in the case of VHL, one of the key things it does is it regulates HIF. And if you have low oxygen levels in the cell will basically say, hey, I need more oxygen, we need more blood vessels. And VHL sits back and is very polite and allows HIF transcription factors to actually then allow the transcription of very important proteins for blood vessel growth, like VEGF. And VEGF then actually will activate the VEGF receptor, which is one of these kinases that I talked about. So that's what happens in low oxygen levels. In normal oxygen levels, what happens is you get VHL then grabbing onto these HIFs and essentially degrading them, preventing them from doing their work. Okay? And you get degradation of HIF alpha. But if you have a mutation in VHL, it replicates the low oxygen levels. The cell is basically crying wolf, saying, hey, I need more oxygen. It produces all of this VEGF. You get more VEGF receptors on the blood vessel cells, and that's what we block with drugs like sunitinib, pazopanib, axitinib. And here we come back to our organ now, and you can sort of see what happens. You have the tumor cell that we see here. You see now there's VEGF being produced. You get these VEGF receptors that basically get activated by the VEGF, and you get more blood vessels inappropriately. All right? And this has resulted in a whole bunch of drugs that have been FDA approved, including, like I mentioned, sunitinib, pazopanib, axitinib, sorafenib, are the kinase inhibitors, these small molecules that I'm talking about. Just a bit more background before I start delving into some of these. Disease aggressivity for renal cell carcinoma really is something that's important for us in terms of how we can talk with patients about what the prognosis is, what the likelihood is of surviving 1, 2, 3, or 4 years, independent of therapy. And this also is beginning to allow us to think about how to categorize patients from a therapy perspective. Okay? And we've observed that different patients' disease is more aggressive than others. We've created relatively simple tools to be able to obtain information, to be able to categorize individuals, and these tools are called risk models. And so the first one that was developed was back in 1999 and 2002. There were publications that came out of Memorial Sloan Kettering Cancer Center that created a risk model that used real simple stuff. The performance status, which is how well is the patient feeling overall, the calcium levels, the hemoglobin levels, the LDH, which is a blood level of a sort of a liver enzyme, and also whether or not they needed to start treatment within 1 year of their initial diagnosis. And using these, they were able to actually categorize people into people whose survival ended up being somewhat better, which is in the blue line here, or somewhat worse, is what we see in the black line. And this provided us some guidance in some of the clinical trial designs. And then there was a slightly newer one, which was then generated out of a population of patients who had actually been on these targeted therapies. It changed a little bit. We got rid of LDH, and we added high white count, and we added high platelet count, but it's the same sort of thing. And if MD Anderson had done one, maybe it would have been identical to this. Maybe 1 or 2 other factors would have come in or come out. But you get the idea here. And this also was very useful in categorizing people into different risk categories. This is sort of independent of therapy, but like I said, as we start learning more and more about the cancer biology and also about the drugs we're using, we're more and more going to have strategies for these different risk groups, because these risk groups are telling us something or hinting at information. And so what we really need to do is we really need to bring this knowledge out of the shadows into the clear light of day so we can really understand what the biology it is that makes these curves happen. Here's an overview of how the drugs that I sort of put in sort of semi-table or sort of in list form before into a table, and I'm going to delve into this table a little bit. So we have first-line therapy, that first line, and then the second-line therapy, and we have, using studies, clinical trials, where several hundreds of people got drug A versus drug B. We could then show drug A was better than drug B, with usually the readouts would be time to disease progression, or in some situations also overall survival. And we have here sunitinib, or pazopanib or Votrient. We have bevacizumab plus interferon in first-line therapy for people who have good to intermediate risk features. And then we have, in people who have poor risk features, we have high-level or high-quality data on temsirolimus. We have some alternatives here. Also in the second-line setting, we'll focus on what the vast majority of individuals in 2016 are individuals who have been on some sort of prior VEGF receptor or VEGF inhibitor, one of these kinase inhibitors. And here we have Afinitor or everolimus, we have axitinib, and we have some new kids in the block, nivolumab that is FDA approved, and cabozantinib, as I mentioned, is kind of coming down the pipeline. So let's talk a little bit about some of the data that have actually generated that table. That table isn't just something that somebody woke up one morning and said, hey, I'm going to make this table. It's based on trials that were done with hundreds of people where we ended up getting these data with very robust endpoints, which we believe are clinically significant. So let's talk about sunitinib or Sutent. It's a small molecule inhibitor. It's that little red thing that's jamming the protein from behaving. And it's officially given 50 milligrams by mouth 4 weeks on and 2 weeks off, although we have data now in retrospect, suggesting that 2 weeks on and 1 week off actually ends up being better tolerated and looks like it's probably not worse from an efficacy perspective. And there are actually several clinical trials. It was at least one prospective, meaning sort of moving forward, testing that this alternate schedule is better than the old-fashioned schedule. So schedule is actually important. It's just an important little point here. This was approved way back, like 10 years ago, and it's still one of the most commonly used drugs in the frontline setting. Why was it FDA approved? Well, it's because when a 750 patient study was performed looking at individuals who were on sunitinib versus people who were on what was back then the standard of care, which was interferon. It's hard to believe, but that's, but that's, and there are some people who've benefited from interferon, but it's pretty clear here that basically what we have here is the probability of not having progressed on this axis here, the number of months that the people were on the drug, and then as the line curves goes down, these are called Kaplan-Meier curves, obviously as it goes down, that means that your disease has progressed. And you want the line to stay up. Perfect would be, this line would just be going across here, people never progress when they're on that drug. So this is definitely less than perfect, the green line. The brown line is better. And the progression-free survival was higher. The other thing was that then they looked at overall survival in this patient population. But what had happened already here was that a lot of people who were on interferon in the frontline setting, all of these people had not previously received any therapy. They then got onto a drug like sunitinib or pazopanib or something like that, and then in overall survival, they kind of might have gotten rescued. So the overall survival curves were not separated as much. So let's talk now about pazopanib or Votrient. So this is another one of these small molecule inhibitors that blocks this protein, this kinase, on the surface of blood vessel cells, VEGF receptor. And it's given 800 milligrams per month a day continuously. We've done less playing around here with schedule, although a lot of us in the clinic, when a patient is on Votrient, starts feeling kind of worn out, we often recommend, hey, why don't you take a break for a couple of days instead of lowering the dose first? And oftentimes that lets the body get better and feel better, and we can recover faster from the treatment. This was FDA approved 3 years later. And so this was FDA approved on the basis of another one of these randomized studies. So this is basically people who had not received prior therapy or had received some sort of old-fashioned immune therapy before. And the computer flips a coin. They either got on pazopanib or they got on placebo, basically a sugar pill. And then they looked to see how long people took till they progressed. And what it showed is this was the overall study population here on the left, that clearly Votrient or pazopanib allowed people to not progress for a longer period of time than people who were on the placebo. And over here we have people who had not previously received any therapy, and we see that those curves spread over even further. And before you say, well, that was kind of unethical to put people on placebo when we knew that had a reasonable idea these types of drugs worked, they then actually got to cross over to the Votrient when they progressed. So it was kind of a Votrient first versus Votrient second kind of study, and for that reason the survival curves were essentially the same. So let's move on to Toracel, or temsirolimus. This is an IV molecule. It's given weekly. And this was FDA approved in 2007. It was a little bit different. This was a study where individuals who now had poor risk features. Remember I talked about those risk algorithms. They had to have at least 3 of those negative features. Actually, there was another feature. They added a 4th one, so they actually had 6 instead of 5. And people had to have those risk features, so they had more aggressive disease, and they were randomized between interferon, which was the standard back in the 2000s, and temsirolimus plus interferon or temsirolimus alone. The primary endpoint here was overall survival. And although it's a little bit hard to see here, you see this is the green curve. These people did live longer, and it was kind of modest, but if you then look at the numbers, you see that it was an 11-month survival for people on Toracel versus 7 months. And this was already, definitely looking better than the 5-month median survival that we've been seeing with poor-risk patients back in the 2000s. So not great, but certainly better than before. So should we use temsirolimus in all poor-risk patients? What we don't have is we don't have good data to really ask the question of whether some of these targeted TKIs that we've been talking about are useful in that patient population. And so Dr. Tenier and Dr. Zarita, Dr. Tenier's here in the audience is going to be talking next, has a study that he's the principal investigator on testing whether or not Toracel and Votrient are as good for this patient population. This is a randomized study. We've enrolled more than half of the patients, and we plan on getting up to about 90 people in this study. So far I've talked mainly about first-line treatment. So you come in, you either had a nephrectomy several years ago, you now are found to have metastatic disease, or you have both at the same time, and Dr. Wood or Dr. Karam or Dr. Mateen perform a nephrectomy, and you're then ready for treatment. So you get that first-line treatment, and then let's say you progress. What do you do in the second line? So remember back in that table that I showed Afinitor or everolimus, I showed axitinib or Inlyta, I showed nivolumab or Opdivo, and I also showed cabozantinib or Cometriq. And so I'll talk, because that's my talk, about the targeted drugs here. Dr. Gao will talk more about the immunotherapies in that situation. So Afinitor or everolimus, this is an mTOR inhibitor. So it works somewhat differently. It actually blocks a protein inside the cancer cell itself. If the cancer cell is kind of a bus that somebody has stuck the accelerator on and the bus is moving too quickly, what the Afinitor does is essentially it slows down the bus. It takes the foot off the accelerator. It slows the bus down. It doesn't actually stop the bus or crash the bus, turn the bus to the left or right. It basically slows down the trajectory of the disease of the cancer cell growth to some degree, and this obviously provides some benefit. Toracel is another mTOR inhibitor. We saw that provided a survival advantage, especially in rapidly growing tumors. So Afinitor in the second-line setting was tested and was approved in 2009, and it was approved on the basis of this study. This is a study that looked at people who had previously, by and large, received either Sutent or Nexavar, and they were randomized between Afinitor and placebo. And there was crossover allowed. So if you were on the placebo and you progressed, you were allowed to get on the Afinitor. And the progression-free survival was definitely in favor of the Afinitor. So here we have this Kaplan-Meier curves again. So remember, this would be ideal if we just had a line across like this. All the way straight down would be the worst possible, and we're trying to strive for that straight line here. And you can see that here the Afinitor is definitely doing better than the placebo. Progression-free survival of about 5 months versus 2 months. And the overall survival, once again, because of the crossover, was no different. So that's why it was approved in 2009. Axitinib, or Inlyta, is another drug that was FDA approved for second-line treatment for renal cell carcinoma, and this was FDA approved in 2012. And this was on the basis of another study where you had people who had progressed either on an immune therapy, this was done in Europe where they were still using a lot of interferon and stuff, or TKI, like sunitinib or pazopanib for the large part, or bevacizumab, and they were randomized between either getting Inlyta or axitinib or sorafenib, which was one of the first FDA-approved drugs for kidney cancer, another targeted drug. Again, for the interest of time, I'm not going to talk about it. We don't use it that much for kidney cancer anymore, although it's still a decent drug. But what they showed is that the yellow line represents the group of patients that were on the Inlyta, axitinib, and they clearly did better. Their disease progressed later than the people who were on sorafenib, although these are not massively different. And if you then start parsing this out and looking at individuals who had previously been on Sutent and then moved on to receiving Inlyta, their progression-free survival was about 5 months. So not that different from axitinib, from Afinitor. So it's pretty clear that anti-VEGF therapy and these mTOR inhibitors themselves are a great advance. There's no question. We are improving survival with these drugs. Things are very different from 2005. But some people never respond. Most people end up having to go on to second or third line therapy, and we need to do better. So what are some novel treatment approaches we're doing? And then let me just focus in on some of the agents that we're currently using. So there's some new inhibitors that I'll just mention. And also there's also a MET and AXL inhibition that I'm going to talk about. And there's a bunch of other cool new things that we're not going to go into in great detail. Just a shout out for this concept. Remember back at the beginning slides, VEGF, if it's broken, HIF goes crazy, you get too much VEGF. Finally, people are developing drugs to start blocking HIF, which is an interesting concept. We don't know yet whether it's better than the targeted TKIs, but it is something that we now finally can do. What about MET and AXL, and what on earth is MET and AXL? Well, so remember I was talking about these various receptors, and we focused mainly on VEGF receptors, where there's another two receptors called MET and AXL, which are on the surface of the cancer cells, as well as on the blood vessel cells to some degree, and these seem to enable metastatic behavior, bad behavior by the cancer. And blocking these makes a lot of sense. We know that MET is found on chromosome 7, and basically we know that, for example, in papillary kidney cancer, when we look at chromosomal gains and losses in the tumors, that MET is probably amplified in these patients, so we get more copies of chromosome 7, thereby more copies of MET. The same is true also in clear cell kidney cancer, so this is a good strategy. We also have data that shows that people who have higher MET expression in their tumors don't live as long. So this is something that we really want to focus on. And so this drug, cabozantinib or Cometriq, is a drug that's not yet FDA approved, but we have some pretty cool data on. And this is an inhibitor of VEGF receptor kinases, as well as the MET and AXL kinases. And they did the owners of this compound did a study where they took 650 patients who had previously received a TKI, and they were then randomized between cabozantinib or Cometriq and Afinitor, and the primary endpoint was progression-free survival. And what they showed was that there's definite improvement compared to Afinitor, everolimus, in progression-free survival. In individuals who had previously just received sunitinib as prior therapy, the progression-free survival compared to Afinitor was even better. So looking pretty promising. And then the overall survival, the initial analysis that was reported in the summertime, suggested there was this trend, and this was unprecedented now in the second-line setting. At that time, there was a trend towards improvement in overall survival. And in the meantime, this has now been shown to be conclusively positive. So cool drug. Some caveats. Toxicities. All right, so this is a drug that actually can make people feel pretty tired. The diarrhea can be pretty terrible in times. And it's a drug that we're learning, if it gets FDA approved, we're going to have to learn how to use, because it's not going to be a totally easy ride for the patients, but we're going to work on making it a better drug. So in summary, here's the overview that I've gone through. We have these targeted therapies, or TKIs, where we have these little chemicals that can basically jam these receptors that are overexpressed in various aspects of the tumor organ. We use these in the frontline setting. Drugs like sunitinib and pazopanib are the mainstays. Temsirolimus for poor-risk patients. We have clinical trials figuring out whether we can do better for the poor-risk patients with these targeted therapies. In the second-line setting, we have Afinitor, everolimus, we have axitinib, and we also have cabozantinib. So what's the future going to hold for these therapies? You're going to hear a lot about immunotherapy. There's a lot of buzz about immunotherapy. Are they just going to take over and we're not going to have any of these targeted therapies? Absolutely not. These drugs have a place. They're going to still have a place. We are not curing everybody with immunotherapy. And our strategy over the next 5 to 10 years has to be to figure out, to look under the hood of the tumor organ, figure out what we need for which patient at what time, integrating immunotherapy with targeted therapy so we can actually get more people towards a cure. These agents at the moment still remain the frontline standards of care for renal cell carcinoma. So we have clinical trials with other agents like immunotherapies, but we don't have anything FDA approved in the frontline space. These drugs clearly help individuals. And what it is and what we need, I think, the help of the patient community is to help us devise these new strategies. We need to get not only smarter drugs, we also need smarter clinical trials. So examples of these combinations, a trial that Matt Campbell, one of our colleagues, is going to be the principal investigator on. This is axitinib plus avelumab, phase 3 study, coming soon. We've got also a study that J.J. Gao is going to be talking about as the principal investigator on, and this is a study that's ongoing of nivolumab versus nivolumab plus ipilimumab versus nivolumab plus bevacizumab. try to say that fast 5 times. And that's ongoing at MD Anderson Cancer Center. And I'll stop there. Thank you very much. Any questions? Oh, all right. No questions.
So we'll do questions at the end of the 3 talks. So now we have actually an international expert in the management of patients with non-clear cell histology, which is quite rare. And Dr. Nazar Tanir, one of our colleagues from genitourinary medical oncology, is going to talk to us about strategies for treating patients who present with metastatic non-clear cell kidney cancer. Nazar?
Thank you, Chris, for the kind introduction, and thank you all for coming, and thanks to the KCA for putting together this conference. So you heard from Dr. Yonash about the different therapies that are FDA approved for kidney cancer. Those drugs are approved based on the most common type of kidney cancer, and that's clear cell RCC. I can tell you in a word about the non-clear cell histologies. In a word, there's really no established agent. We use these drugs that Dr. Yonash talked about, the different tyrosine kinase inhibitors or anti-VEGF therapies, the mTOR inhibitors, but really we do not consider any of these as a standard of care because there has not been this large phase 3 trial comparing one of these agents with something else to show that these drugs are really beneficial. So what are these different histological subtypes that we refer to as non-clear cell renal cell carcinoma? So you see the list here, papillary type 1 and type 2, renal cell carcinoma, chromophobe. There is a rare tumor called collecting duct or Bellini's tumor. There is also another even more rare tumor that is called renal medullary carcinoma that afflicts mostly in the U.S. African American young patients who have sickle cell trait. There is a rare tumor that's called translocation renal cell carcinoma or XP11.2 that afflicts younger people as well, mostly females. And when we do not really know what this disease is, we refer to it as unclassified. That's really a reflection of our still, lack of knowledge about the molecular aspect of this subtype of RCC. So we dump it into an unclassified basket. And there are even some more rare tumors, such as MTS or mucinous tubular and spindle cell carcinoma, and then some case reports have surfaced with even rarer tumors. Now, oncocytoma is a benign tumor of the kidney, rarely becomes aggressive and metastasizes, and for all practical purposes, it's cured. Patients with this disease, with this tumor, are cured with surgery. Now, with each one of these tumors, including the clear cell, the most common type, as well as the non-clear cell I just listed, there is also an added feature that can make the disease even more aggressive. I describe this as having a turbo charge on your vehicle makes it even more aggressive. So that's the sarcomatoid dedifferentiation. So there is a plethora of genetic alterations underpinning each one of these tumors. And as I said, the non-clear cell basket of diverse histologies represents about 25% of all kidney cancers. Papillary type 1 and type 2 and the chromophobe are the most common subtypes with varying prognosis. So you heard from Dr. Nash about the prognostic models that have been established, and that's basically looking at patients who have different performance status, how they function, how active they are, how they're able to perform activities of daily living. We look at the time of initial diagnosis of their kidney cancer and when they develop metastatic disease and require initiation of systemic therapy. And we look also at laboratory parameters such as, hemoglobin, anemia, whether they're anemic or not, and whether they have high calcium in their serum and other laboratory abnormalities. Now, this is a model that is now frequently used, established by the International Metastatic Renal Cell Carcinoma Data Consortium, and they looked at these the patients who have the clear cell, the most common type of renal cell carcinoma, and those who have the non-clear cell that I showed you earlier in the slide. And what they found was patients who have a non-clear cell renal cell carcinoma subtype are usually younger, have more anemia, and have usually a higher neutrophil count. That's a form of a white blood cell count. And their outcome is worse. And in that study, again, this is a retrospective review of a large database, the median survival of patients with non-clear cell histology was about 1 year compared to about 2 years for patients with clear cell histology. Now, there have been some retrospective studies, several years ago now, published looking at the role of TKIs, which you heard earlier, these tyrosine kinase inhibitors, in retrospective studies. What's their role, what's the outcome of patients with these non-clear cell histologies when they were treated with these TKIs. And as you see here in the slide, the bottom line is that the median progression-free survival, that basically reflects the time from initiation of the drug until the disease progresses, or unfortunately the patient dies. And these median progression-free survival are short. They're shorter compared to what we observe in patients with the most common type of renal cell carcinoma, the clear cell type. Also, when you look at the response rate, that is also a definition, how much did the tumor shrink, except for chromophobe, which in one study, the retrospective study, a small number of patients was associated with a 25% response rate. When you look at the other, the response rates are really low, much lower than what we see in patients with clear cell RCC. Now, what about some of these earlier trials with sunitinib in non-clear cell RCCs? Here is a list of 4 of them. The largest was a study that we conducted here at MD Anderson and published 4 years ago. And the bottom line here, except for the Korean study by Lee et al. Here, that yielded a response rate of 36% and 26% in the papillary histology. The other trials showed that the response rate in these tumors is really low. And again, when you look at that median PFS, it is about 6 months or less. And when you look at survival in these 2 studies up here, this one conducted at Memorial Sloan Kettering, and this was a French study. When you look at the survival, it's really disappointing that the median survival of patients with metastatic non-clear cell RCC treated with sunitinib, which is certainly a standard of care in the clear cell histology and one of the earlier drugs FDA approved more than 10 years ago. The survival of these patients is disappointing in that it is about 18 months or so. So what about looking at mTOR? You heard about the phase 3 trial of temsirolimus versus interferon. This is the only phase 3 trial that recruited patients with non-clear cell histologies. About 20% of the patients who were enrolled in this trial had the non-clear cell histologies. Again, the median OS, when you compare non-clear cell versus clear cell, was comparable with temsirolimus. Again, better than what you see with interferon alpha, which was used as comparator. The French conducted a phase 2 trial with everolimus in papillary RCC called the RAPTOR trial, and the primary endpoint of that trial was progression-free survival rate at 6 months. And here the data is median duration of exposure, meaning use of everolimus in study was less than 5 months. By investigator, the patient, the physicians treating those patients, median progression-free survival was about 7 months. And about half the patients, or a little over half, were progression-free at 6 months. So really nothing really to write home about or be excited about. What about another drug? This is another tyrosine kinase inhibitor, but that blocks EGFR, epidermal growth factor receptor, a drug that's approved for lung cancer, adenocarcinoma of the lung. This was a small study conducted many years ago by the Southwest Oncology Group, and in a 45 patient trial, 7 of those were ineligible, the response rate was 11%. The estimated 6 months overall survival was 87%, and the estimated median overall survival was 27 months. Again, the FDA did not approve this agent, even though there was some promising activity in papillary RCC because of lack of a large, properly powered phase 3 trial. You heard from Dr. Rash about the cabozantinib. This is actually a drug that was tested in papillary RCC before cabozantinib. It's a cousin to cabozantinib. It is a drug that was manufactured by Exelixis, the maker of cabozantinib, and it was tested in patients with papillary RCC using 2 different dosing schemas, either daily dosing or intermittently 5 days every 2 weeks. And the primary endpoints were objective response rate, and the secondary endpoints, progression-free survival and overall survival. 74 patients were recruited to the study, and here are the 2 cohorts, with the one with intermittent dosing and one with the daily dosing. And then here, when you look at overall response rate, 13.5%. And when you look at the median PFS, about 9 months. Interesting, but then you look at the biomarker results of this study, which is the most interesting part of the trial. About 50% of the patients, so 5 out of 10 patients who had germline mutation of MET, that basically they have the inherited syndrome of papillary type 1 RCC, and the response rate was 50%. When you look at the others, patients who had the somatic mutation, that is, they did not inherit the germline mutation, but their tumor showed mutation in that MET oncogene, 1 responded out of 5, and that's basically 20%. And then there were, again, low responses. So the take-home message from this trial was, yes, there was some activity, but it appeared that the patients that benefited the most from this c-MET inhibitor were patients who had the inherited papillary type 1 syndrome. But the trial was not developed any further, and we still are looking for an agent that is effective in papillary RCC. This is a sequel trial to the one I showed you earlier that we published 4 years ago, and this trial we published just last year. This was a collaborative study that we led here at MD Anderson, comparing 2 agents that are FDA approved for this cohort or this diverse group of non-clear cell histologists. So we dubbed this trial the ESPN trial. It's everolimus versus sunitinib prospective evaluation in metastatic non-clear cell RCC. So the goal of the study was to compare sunitinib and everolimus in these patients with the different histologies, and we looked at, for primary endpoint, progression-free survival in the first line. We did allow crossover at the time of progressive disease with the first-line agent. Secondary endpoints were survival, objective response rate, PFS or progression-free survival in the second line, objective response rate in the second line. But the main goal of this trial, the main objective, in addition to the clinical parameters our endpoints we talked about, was to really understand the biology of these different histologicals and to create a biorepository where we collect tissue from nephrectomy and biopsies on these patients, as well as blood, to really understand more about these diverse histological subtypes of RCC. So here's the treatment schema. Patients with non-clear cell histologies were randomized 1-to-1 to receive either everolimus or sunitinib, and at crossover, take the other agent if they wish to do so and their condition permitted. The trial was stopped earlier than the target goal of 108 patients because the data safety monitoring body looked at the results and at preliminary analysis found that patients who were treated with sunitinib had actually better outcome than patients who were treated with everolimus. So this was counterintuitive because we were thinking that for patients with non-clear cell histologies, they would be benefited more by the mTOR inhibitor, everolimus, based on that phase 3 trial that I showed you, the temsirolimus versus interferon trial. So we stopped the trial after 73 patients were recruited, and here are the results. About three-quarters of the patients had prior nephrectomy, about two-thirds had crossed over to the other agent, and unfortunately, over 50% of the patients had died. But when you look at the responses, here you see that the response rate is very low, less than 10%. So less than 10% of patients receiving sunitinib or everolimus in first line responded, had significant shrinkage of their tumors that we arbitrarily cut off at 30%. So that's really disappointing compared to what we normally expect to see with these agents, especially sunitinib, for example, in patients with clear cell RCC. So again, the results were disappointing in the first line and in the second line. Interesting, and you have the asterisk there, the patients who benefited the most from either drug were patients with chromophobe RCC, which is a rare tumor that about 5% of patients with RCC will have. And here are, you saw similar data. I don't want to dwell on it. The red curve represents patients treated with sunitinib. The green curve, patients treated with everolimus. And of course, the curve that's on top looks like it's better. But this was not statistically significant. So our hypothesis initially that patients with these rare non-clear cell histologies will be best served, best treated with better outcome when they receive everolimus did not pan out. So summary of that trial was both agents, everolimus and sunitinib, yielded modest efficacy in patients with metastatic non-clear cell RCC. There were trends for longer progression-free survival in first line and longer overall survival with sunitinib, but this came at a cost of higher rates of toxicity with sunitinib compared to everolimus. Chromophobe RCC showed higher objective response rate, longer progression-free survival, and longer overall survival compared with the other non-clear cell RCC subtypes. The Duke Center led a similar study in 19 sites in 3 different continents, in 3 different countries, basically, US, Canada, and the UK. And they had identical design of randomization, that's random allocation or assignment of therapy to everolimus or sunitinib, but there were some differences in the eligibility criteria. They did not include patients who had sarcomatoid clear cell, who had sarcomatoid dedifferentiation or features, and they did not allow, as we did in our trial, to allow patients to cross over after they have progressive disease with the first line. But their results were very similar. Again, you see here the Kaplan-Meier curves. The patients treated with sunitinib are represented on the blue curve here, and the everolimus on the red curve. And patients treated with sunitinib had a better progression-free survival, longer than patients treated with everolimus. Same thing with overall survival. Results, again, consistent with what we saw in our trial. So, summary for the Aspen trial led by Duke, sunitinib yielded a significantly longer progression-free survival than everolimus, and the benefit with sunitinib was noted in patients with good and intermediate risk disease, papillary, and the unclassified subtypes. However, everolimus did have good results in patients with poor risk disease, which is not surprising considering that mTOR inhibitors, especially the study with temsirolimus, showed improvement in poor risk disease. And then the chromophobe subtype, as already alluded to. Now, we are doing extensive molecular analysis on these tumor subtypes, and it appears that patients with chromophobe histologies have a higher than what is expected of TSC1 mutation, a mutation in the gene that's called tuberous sclerosis complex gene 1. And that makes these tumors chromophobe sensitive to blockade by the mTORCO1, temsirolimus or everolimus. But both these agents result in short progression-free survival times and low response rates, and that basically underline the importance of continuing research to find more effective therapies for these patients with non-clear cell histologies. But this has to be based on a better understanding of the biology of these tumor types. Now, what about some of the ongoing clinical trials for papillary RCC? Here I list several for you. This is a trial finished by SWOG, looking at a c-MET inhibitor here with erlotinib, and the trial was negative. A couple interesting trials being conducted right now at the NCI. This agent, vandetanib plus metformin, and then bevacizumab plus erlotinib in the hereditary leiomyosarcoma type. Those are the patients who have the inherited syndrome that leads to development of a very aggressive papillary type 2 RCC. But this trial is also for patients who don't have the inherited syndrome, they have sporadic papillary RCC. There have been some interesting results with this combination, and I think this seems to be something that we need to validate and moving forward, conduct a larger trial to really see if this would be a standard of care in the future for patients with papillary RCC. An interesting trial that was led or sponsored by AstraZeneca and was conducted in multiple sites here and in Europe used a pure c-MET inhibitor for patients with papillary RCC. This was a single-arm study of a 90-patient trial. We await the results of this. There are a lot of tissue-based assays looking at the c-MET alteration and the impact of this agent, that's a pure c-MET inhibitor, to see if we can identify a subgroup of patients with papillary RCC that benefit the most from c-MET blockade. What about ongoing clinical trials in not just papillary, but the non-clear cell in general? And here are some of these trials. This is being conducted at Memorial, combining bevacizumab, the anti-VEGF, plus everolimus. There is a Korean study as well as a study at Mayo looking at pazopanib in this diverse histological group. And I think, here I'd like to pause and emphasize a couple important studies that we are conducting in patients with renal medullary carcinoma. I mentioned to you earlier that this is a rare tumor that's devastating, unfortunately, that afflicts young people with sickle cell trait. In the U.S., these are African American, but we have seen some patients who are actually Caucasian who have sickle cell trait who also can develop this devastating disease. So until recently, there was never a trial for these rare tumors, and in particular renal medullary carcinoma. So now we have two trials at MD Anderson, one using an EZH2 inhibitor. This is the name of the drug. It's from a company, Epizyme, and we are conducting this trial in patients with metastatic renal medullary carcinoma. And we have seen already some interesting, some promising results. 2 of the 6 patients we have enrolled have actually responded to this agent. So there is hope that hopefully as we continue developing this drug, as we treat more patients, that we will see consistent result with activity of this agent in patients with renal medullary carcinoma. But we know that from previous experience that there is no one drug that's going to cure kidney cancer. So we are working to combine an agent such as tazemetostat, the EZH2 inhibitor, with immune therapy. So this is another trial that we have at MD Anderson here that we are conducting in RMC patients using a PD-1 antibody, this agent from Merck, in patients with RMC. And there are some other drugs that we have set our sight on to try to test in this disease. So the last 2-3 slides, I want to just tell you how I treat my patients with non-clear cell RCC. So for chromophobe RCC, those patients have usually a more indolent course. They do live longer even without treatment. But obviously the disease is not curable when it is in the metastatic setting. But any VEGFR TKI, as you know, the experience with sunitinib and pazopanib have led us to believe that there is some activity with the VEGFR TKI. But these are patients, as I said, because of the TSC1 mutation, these are patients who are most likely will respond to an mTOR inhibitor such as everolimus. I mentioned about RMC, how we treat patients with RMC. Chemotherapy has been the mainstay, and this is the same chemotherapy we use to treat patients with bladder cancer. Some of the old cytotoxic agents have helped some patients, but unfortunately, the vast majority of these patients will have then progressive disease because they develop resistance, and we know that chemotherapy is not a curative therapy for these patients. What about sarcomatoid? This is a very aggressive disease, and it can occur with any of these subtypes. Our approach to treat those patients have been to use a combination of cytotoxic chemotherapy plus tyrosine kinase inhibitors. But this is a situation, an opportunity where we could use an immune checkpoint inhibitor in this disease. And this is based on some observations in patients treated with these immune checkpoint inhibitors, particularly the PD-1 inhibitors, where we've seen patients who have sarcomatoid differentiation and more than 90% of their tumors respond dramatically. So there is hope that immune checkpoint inhibitors will hopefully, once for all, change the outcome of this dismal disease. For all other subtypes, it's clinical trials, and clinical trials. So my conclusions, there is no established standard of care for patients with non-clear cell RCC. As I mentioned at the outset, the anti-VEGF TKIs are less effective in non-clear cell RCC than clear cell RCC. Temsirolimus, which is a standard of care for poor risk disease, is a poor standard of care for patients with non-clear cell RCC. There may be a role for c-Met inhibitors in patients with germline mutation of c-Met in papillary RCC. The role of cytoreductive nephrectomy, as Dr. Karam earlier alluded to, is not established, is not defined yet for non-clear cell, as it has been in patients with clear cell. All patients with metastatic non-clear cell RCC should be referred, in my opinion, for enrollment on clinical trials. There are data now that are available from the TCGA to develop rational targeted therapies based on relevant targets in chromophobe and papillary RCC, but it's only through transformative biology-driven trials that we can hope to make a dent in this disease and improve clinical outcome. Trials with immune checkpoint inhibitors are planned, and I thank you very much.
And again, we'll do questions at the end. I see a lot of you feverishly writing notes. I just want to again remind you that all of these lectures are going to be available online for free at the Kidney Cancer Association website in a few weeks. So we're going to finish off with Dr. J.J. Gao, again, another colleague from GU Medical Oncology, who's going to talk to us about some of the exciting developments in immunotherapy for kidney cancer, and particularly focusing on the immune checkpoint inhibitors. J.J.?
How come I have so many? this. Sorry, I only saw. That should be for. Thanks. Thanks, Chris. Good afternoon, everybody. Sorry about the technical difficulty. So I'm going to give you a quick review of the history of immunotherapy for kidney cancer. But more importantly, I will share some very exciting data on the new immune checkpoint therapy. So why are we interested in immunotherapy? So the short answer is the immune system actually can be activated to kill tumor cells. However, the immune system kills tumor cells in a very different way from the traditional chemotherapy and the new target therapy as discussed by Dr. Tania and Dr. Jonas a moment ago. So first, immunotherapy is adaptable. So when a tumor cell changes, the immune system can change as well to track the tumor. Second, it's very specific. So immunotherapy actually just kills the tumor cells and spare the healthy host cells. Third, it has great memory. So even after a tumor cell hibernates for like 3 or 5 years, after this tumor cell wake up, the immune system can still recognize it and try to kill it. Therefore, there is this long-term survival potential for immunotherapy. So through history, scientists and clinicians actually develop different strategies for immunotherapy. So I will only focus on cytokine therapy and also immune checkpoint therapy because these are two types of immunotherapies that are being used in the clinic to treat patients. So cytokine therapy was initially developed in the 1980s. The first breakthrough of cytokine therapy is known as high-dose IL-2 therapy. This was eventually approved by the FDA in 1992 for the treatment of metastatic renal cell carcinoma. And in addition to high-dose IL-2, interferon alpha and beta were also used for kidney cancer, as Dr. Jonas already talked about a moment ago. So, and here's the data on high-dose IL-2 therapy. Among 255 patients who were treated with high-dose IL-2, 37 patients actually had a response to high-dose IL-2. And so the blue line actually showed, the green line actually showed the patients who had complete response to high-dose IL-2 therapy. As you can tell, these patients can live very long, up to 10 years or beyond. So for those patients who only had partial response, which are indicated by the yellow line, the median survival is much lower. It's only about 2 years. So here are the pros and cons of high-dose IL-2 therapy. First, it can cause long-term survival of 10 years or beyond. However, the response rate, as I mentioned, it's very low. Only less than 7% of patients had complete response, and only about 8% of patients had partial response. The overall response rate is less than 15%. And the other 85% of patients actually didn't benefit from high-dose IL-2 therapy. Plus, high-dose IL-2 therapy has very significant toxicity. So these patients often will receive ICU care. They can develop septic shock, heart failure. They normally gain 40 to 50 pounds of weight within about a week. So because of this, high-dose IL-2 therapy are limited to healthier and younger patients with good organ function. Interferon therapy, as mentioned by Dr. Jonas a moment ago, has been tested in a phase 3 clinical trial, either as a single therapy or in combination with a VEGF inhibitor. It's called bevacizumab. And as you can tell from the data here, the response rate to interferon gamma for patients with metastatic kidney cancer is about 13%. And when interferon was combined with bevacizumab, the response rate was about 25%. And the median progression-free survival, which is the time that will keep the tumor from not progressing, is about 5 months. And then the combination therapy of interferon gamma plus bevacizumab, the PFS was about 8 months. However, the overall survival of interferon plus bevacizumab actually didn't increase comparing to interferon monotherapy. So interferon therapy definitely showed some modest activity against metastatic melanoma. However, the most exciting development in the treatment of renal cell carcinoma is the new immune checkpoint therapy, which was developed by Dr. James Allison, who is the director of the immunotherapy platform at MD Anderson. So this is a true revolution of treatment for not only renal cell carcinoma, but also many other types of cancer. So how does immune checkpoint therapy work? So this cartoon actually shows the mechanism of immune checkpoint therapy. In order for the T cells, which are the professional killer cells for tumor cells, to be activated for tumor cell killing, we need two sets of signals between the T cells and the antigen presenting cells. The first set of signal is provided by the T cell, by the interaction between the T cells and the tumor antigen that's presented on a molecule. It's called MHC on the antigen presenting cells. The second set of signal is provided by the interaction of a molecule named CD28 on the T cells and B7 on the antigen presenting cells. However, T cells also have this built-in inhibitory molecules known as immune checkpoints, including CTLA4 and PD-L1. So this inhibitory mechanism is to make sure that T cells will not get excessively activated to the point that it will cause damage to our body. So it's like the braking system for a car. So it's for preventing you from speeding too much and cause accident. What Dr. Allison found was if you use an antibody to block these inhibitory molecules, such as anti-CTLA4 or anti-PD-1, you actually can cause augmented T cell activation for tumor cell killing. So the first immune checkpoint agent was known as anti-CTLA4 or ipilimumab. It was tested in advanced metastatic melanoma patients. So on average, metastatic melanoma patients can live just a little bit longer than 12 months. So when these patients receive ipilimumab, as you can tell from the data here, over about 20% of patients can actually live almost up to 5 years. So despite the fact that the response rate is very low, this data is still pretty striking. So here is an example of a patient with response to ipilimumab. So this patient actually had 31 lung metastases and also a small brain metastasis. And after just 4 doses of ipilimumab treatment, all the lung metastases actually went away. In addition, the brain metastasis also went away. So because of this striking finding, so immunotherapy was actually regarded as breakthrough of the year by the Science magazine in 2013. So the other immunotherapy agent is known as PD-1 or nivolumab, was also tested first in metastatic melanoma patients, either as a monotherapy or in combination with ipilimumab. So as you can tell from what's called the waterfall plot from here, so nivolumab alone actually can cause a significant number of patients have tumor regression, and ipilimumab alone cause less tumor regression. But when you combine these two together, the majority of patients actually have regression of their tumors. And here is the summary data. as you can tell, nivolumab alone can cause a response rate, complete response rate of almost 9%, partial response rate of about 35%, and ipilimumab alone can cause a very low complete response rate, but a partial response rate of about 17%. When you combine these two drugs together, the complete response rate was about 12%, and the partial response rate was about 46%. So, and also about 13% of patients actually have their tumor stable. So overall, almost 80% of patients will have their tumor controlled. So comparing to the historical data of these patients surviving for about a year, this is really, really remarkable. So what about immunotherapy in kidney cancer? So ipilimumab was actually tested in a phase 2 clinical trial for patients with renal cell carcinoma. So in this trial, patients were separated in 2 treatment groups. The first treatment group received 1 dose of ipilimumab at 3 milligram per kg, followed by 3 doses of 1 milligram per kg of ipilimumab. And only 1 patient out of 21 patients had a partial response that lasted for about 18 months. So the patients in group 2 were treated with a higher dose of ipilimumab. It's 4 doses of 3 milligram per kg, and 5 out of 40 patients actually had partial response between 7 to 21 months. So that's about 12, almost 13% of response rate. So that's very similar to the metastatic melanoma data. The other immune checkpoint therapy antibody, nivolumab, was also tested in renal cell carcinoma in a phase 3 clinical trial by using everolimus as a control. So this was used as a second-line therapy. And as you can tell, nivolumab, in the nivolumab treatment group, which is represented by the blue line, and the patients apparently live much longer than patients who were treated with everolimus. Overall, the median survival increased from about 20 to 25 months. So this trial was actually led by Dr. Tanier and Dr. Sharma at MD Anderson, along with the Memorial Sloan Kettering group. So very interestingly, in the subgroup analysis, for those patients who have poor risk factors, as discussed by Dr. Jonash and Dr. Tanier, they actually benefited the most from nivolumab treatment. So just to give you a case with patients with poor risk factor, this was actually one of my patients. So she is a 73-year-old female with a metastatic clear cell renal cell carcinoma in bilateral lungs with lymphocytic spread. Her disease was also in the lymph nodes, bones, diagnosed in October 2013. So after that, she was treated with Votrient, axitinib, and everolimus, but eventually had disease progression in November last year. So at that time, she had constant cough to the point that she couldn't eat or drink very much. She was very short of breath. She was on oxygen. She was wheelchair bound. So I already discussed with her family about home hospice arrangement. But at that time, nivolumab was approved. So she received her first dose of nivolumab on November 18th last year. And as you can tell, at that time, she had lots of disease in her lungs. In her right lungs, in the left lungs, it's not that much, but she also had lots of fluid built up in her lungs due to cancer. But after 3 months of treatment with 6 doses of nivolumab, you can tell the cancer was almost completely gone. The fluid also went away. So currently, I just saw her last week. So she is able to go to church. She is able to cook for her husband. So she's doing quite well. So what about the combination therapy with ipilimumab plus nivolumab in metastatic renal cell carcinoma? So this is the phase 1 study, basically testing 2 different dose regimens of combination with nivolumab plus ipilimumab, followed by maintenance nivolumab alone. So, and here is the data. So in the first dosing regimen, so patients were treated with 3 milligram per kg of nivolumab plus 1 milligram of ipilimumab, 1 milligram per kg of ipilimumab. And in the second dosing regimen, patients were treated with 1 milligram per kg of nivolumab plus 3 milligram per kg of ipilimumab. As you can tell, the response rate are very similar in both groups, and except in the second group, there is higher stable disease rate than the first group. However, the second group had significant toxicity. Therefore, the dosing regimen of the first dose regimen was chosen for a phase 3 clinical study, which is a randomized open-label study of nivolumab plus ipilimumab versus Sutent in patients with previously untreated metastatic renal cell carcinoma. This was led by Dr. Tenier and Dr. Sharma. I'm involved in this trial as well. So currently, this trial has been completed, and we are expecting to have data within the next several months to a year. So due to these developments, so there are multiple trials going on with immune checkpoint therapies in patients with renal cell carcinoma. So according to the website clinicaltrials.gov, which register all the clinical trials in the U.S., there are at least 52 clinical trials with immune checkpoint therapy on patients with renal cell carcinoma. So it's essentially impossible for me to list all these trials here. And so I will list only a few trials that are ongoing or are going to be open at MD Anderson. So the first one was the phase 3 trial to test the combination of nivolumab plus ipilimumab versus Sutent in patients with metastatic renal cell carcinoma. That one has been completed. And there is another trial, it's a pre-surgical trial, testing nivolumab plus nivolumab as a monotherapy or nivolumab plus bevacizumab or ipilimumab in patients with metastatic renal cell carcinoma, but with tumor amenable to either post-treatment biopsy or resection. So the third one was also a pre-surgical trial using another immune checkpoint therapy agent. It's called tremelimumab, which is an anti-CTLA-4 antibody, plus or minus cryoablation, which can be a treatment for cancer, for metastatic renal cell cancer as well. So the fourth one was a phase 3 trial, as mentioned by Dr. Jonash already, to test avelumab, which is actually another anti-immune checkpoint therapy. Is called anti-PD-L1 therapy in combination with axitinib versus Sutent as a first-line therapy in renal cell carcinoma. And the fourth one was a phase 1/2 study by combining pazopanib with another immune checkpoint therapy. It's called pembrolizumab. So clearly, immune checkpoint therapy has brought lots of excitement, hope, and clinical benefits to our patients. However, just like everything else in our life, nothing is perfect in this world. So because immunotherapy actually can be associated with significant toxicities known as immune-related toxicities. To give you an example, this is the phase 3 data testing nivolumab or ipilimumab or the combination therapy in patients with metastatic melanoma. So as you can tell, nivolumab alone can cause grade 3 or grade 4 toxicity in about 16% of patients. So grade 3, grade 4 toxicity means a patient will have to be admitted to the hospital for taking care of their side effects. So for ipilimumab alone, so about 27% of patients will be admitted to the hospital for the management of these toxicities. But when you combine these two drugs together, more than 50% of these patients will end up in the hospital. So these toxicities will have to be managed very early on, and otherwise they can be very deadly. So the most important immune induced toxicities include pneumonitis, which can present as just very subtle short of breath, especially when you are moving around. So the second one is colitis, which generally present as very profuse diarrhea and also abdominal pain. The third one is hepatitis, which can be very vague symptoms, including fatigue and abdominal pain. The fourth one was called hypophysitis, or inflammation of the hypopituitary gland. So this one can present as headache, vision change, fatigue, and a low blood pressure. And the most common one is actually dermatitis, which is rash. So for most of the time, the rash is actually is very subtle. It can be managed with topical steroid. However, if the rash, covers more than a third of your body, or it becomes into like blister, so that's very dangerous. Then infection can happen. You can it can become become life-threatening as well. So just to give you a few examples of this immune-induced toxicity, the first one is pneumonitis. So this patient was treated with ipilimumab, and after I believe 2 or 3 doses, he developed pneumonitis, as you can tell on the CT scan, with this ground glass opacity in bilateral lungs. And this is inflammatory colitis caused by ipilimumab as well. As you can tell, this patient has lots of ulceration and inflammation in the colon. When we biopsy the colon, we can see lots of inflammatory cells infiltrating into the colon that caused significant diarrhea. So the third most important one was hypophysitis. So this is the normal hypopituitary gland of a patient before therapy, but after ipilimumab therapy, you can see the pituitary gland was enlarged and also inflamed. So we have been working very hard over the past several years to develop some algorithms to manage this immune-induced toxicities. So we have developed order sets to order different labs for different types of immune-related toxicities. We also developed algorithms to manage different types of immune-induced toxicities. So, but the key on your side is actually whenever you have these symptoms when you are on immunotherapy, you have to call your treating physician right away. So to give you an example, we had a patient who was treated with ipilimumab, and he developed diarrhea. However, he didn't even tell us until about a week later. When he got here, we gave him lots of steroids, lots of anti-inflammation agents, but he had so much diarrhea, and then he ended up staying in the hospital for about 2 to 3 months. So eventually we controlled his diarrhea, and he went home, and then because he had such poor nutrition status, he actually developed syncope and then a cardiac event, and then died at home. So, but if you tell us about this immune-induced side effects earlier, we can get you to the hospital earlier. We can definitely manage it well. So overall, in summary, IL-2 therapy provides long-term survival, but with low response rate and a significant toxicity. Anti-CTLA-4 and anti-PD-1 each have modest activity against renal cell carcinoma. Combination therapy, including anti-CTLA-4 and anti-PD-1, provides higher response rate, but this higher response rate was also associated with significant immune-related toxicities, and we have to manage these toxicities early. So thank you very much for your attention. I will be very happy to answer any questions. I also want to thank you for your consistent support of our cancer research. Without your participation of these clinical trials, so these new developments would not have been possible. So together, we are making cancer history. Thank you.
Can I have Dr. Yonash and Dr. Tannir come up? Does anyone have any questions? Okay, it's all clear. Never mind, guys. All right, so why don't we do this? Why don't we take like 15 minutes and go out and get lunch and bring it back in here, and then we'll do a working lunch so we can finish early, and I can get my hair cut. I don't appreciate, you're probably not sympathetic to that, but. All right, so go ahead and get your lunch and then come back in and we'll get started.
There's a few more in that folder in the top right corner if you want to.
We're here?
Yes.
Okay.
Smaller mass in the left kidney. And there's a tiny cyst probably in the liver. And that's most of what I see for now.
Okay, so a locally advanced tumor involving the right kidney with a renal vein and IVC thrombus going into the vena cava, and then another small tumor present on the left kidney. The significance of Jehovah's Witnesses is that they don't allow blood transfusions. So if you get into trouble during surgery with bleeding, you're really in trouble. So Dr. Mateen, how would you approach the management of this case?
So the patient needs a workup for metastatic disease, which I don't know how much you want to cover that, but CT of the chest at the minimum. And then depending on lab studies and there are any signs or symptoms, maybe additional things like bone scan, for example.
CT chest was negative.
There we go. Thank you. But basically, patient needs surgery. The Jehovah's Witness factor is an important one for consideration, and as long as they're willing to accept the risks, I would address the right side first and treat that. I would have something what we call like a cell saver, as long as, so Jehovah's Witnesses come in many different flavors and tolerances. Some will accept having their blood drawn, for example, during the surgery, and as long as it remains in continuity, we can then give it back. And so that's called a cell saver that allows us to do that. Some will not accept that. So it kind of requires some discussion. But assuming they accept a cell saver, I would use that during the operation. But there would have to be a very clear understanding with not only the patient but the family that if we do get in some serious trouble, what do they really not want blood transfusion? Sometimes you actually have to talk to them in private and not have family there, because then they'll say, you know what, maybe I'll take a blood transfusion if it's really life or death. So anyway, it gets complicated with that, but it's important to discuss it. Technically speaking, I would do the right side first. Probably would address the left side at a future date.
How would you address the left side?
I do a partial removal.
Okay,
Yeah.
partial nephrectomy?
Partial nephrectomy, no
Would you
question.
do it open, laparoscopic? How would you do it?
I don't know. It's hard to tell a little bit with this. Possibly laparoscopic, possibly robotic.
But the other case you would do open?
Correct. Yeah, the right side I would do open. Yeah, midline incision.
Anyone have any differing thoughts?
I agree, Dr. Mateen.
Any role for chemotherapy or targeted therapy here?
No. No, there is no indication for giving her any systemic therapy.
So it won't
Especially with
shrink-
elevated liver enzymes.
It won't shrink the tumors or make it easier?
It can make the liver condition worse.
Okay.
Her
All right, so the patient
LFTs
did undergo right radical nephrectomy. This patient actually did allow cell saver. We lost 100 cc's on the IVC thrombus, and then we did an interval left partial nephrectomy with intraoperative ultrasound. Again, and minimal blood loss thanks to the cell saver and attention to detail. So let's move on. This is a 91-year-old African-American gentleman who presented with lower urinary tract symptoms and symptoms of dysuria. They thought he had a urinary tract infection. He has a history of hypertension, a remote history of seizures that are thought to be related to possible mini strokes. Never had surgery. These are the medicines that he's taking. Good performance status, actually excellent performance status. His EGFR is 70, so that's his glomerular filtration rate. Labs otherwise normal. And his CT scan of the chest is negative. So here's a look at his films. You can see he has a very large cyst involving the left kidney, huge cyst. And this is actually a hyperdense cyst right here. Hyperdense just means that it's a cyst filled with protein or blood. He's also got cystic disease involving his right kidney. There's a cyst there, there's a cyst there. And he's got a tumor involving the lower pole of his right kidney. Right there, I'm circling it. You can see this huge cyst on the left-hand side, but a small tumor measuring about 5 centimeters occupying the lower pole of the right kidney. This is another look at the tumor in cross-section here. So, Dr. Karam, what are your thoughts?
Usually you don't ask about thoughts. Usually you just want one single answer, but I would do a partial nephrectomy on this patient.
So
if he is healthy.
You would do a partial nephrectomy on a 91-year-old?
Yes.
Okay. Dr. Mateen, what are your thoughts?
Yeah, I mean, I think I would present that option. I would present the alternative of a biopsy on the very small chance that this could be a benign tumor if the patient wanted to try to avoid surgery in view of his age. On the other hand, he really seems to be doing quite well. And I think what's more important than age, I think, is their comorbidities, which really primarily determine how patients will do, not so much age by itself. So, but I would still present the option of maybe a biopsy, and then after that, depending on findings, proceeding with a partial, and the other option would be ablation. It requires discussion.
Okay, so what would you recommend?
I think if you wanted something definitive, it would be a partial nephrectomy, and given that he's doing really quite well overall, that would be the primary consideration.
Well, again, although I agree with you that age is a number, it's more physiology that you're interested in. I did approach the idea of doing surgery on a 91-year-old with a bit of trepidation. So we went ahead and did a biopsy, and the biopsy revealed clear cell renal cell carcinoma. So any changes in your recommendations based on that, Dr. Karam?
No.
So you would do what?
Partial nephrectomy.
Open or laparoscopic?
I have to look at more films, but it looks like it's manageable robotically.
Dr. Mateen, any thoughts?
I agree.
Okay, you know, on the right partial nephrectomy, this was the pathology T1B. Of note, at the time of surgery, I noted that the tissue is extremely friable. It's very difficult to suture things. I don't know if that's because his kidney was 91 years old or what the deal was, but it was quite different from some of the younger patients. He did develop a urine leak postoperatively, but it's being managed conservatively, and he's doing quite well. All right, so we'll move on to another case. So this is a patient, 57-year-old African American who has a history of hepatitis C and also a history of renal cysts. And because of that history of renal cysts, his doctor ordered imaging to follow up on those renal cysts. Again, he has hepatitis C and reflux. He has a previous history of an appendectomy and a laminectomy. He had a CT scan done of his chest, which revealed indeterminate pulmonary nodules. And what that means basically is tiny nodules that are too small to biopsy, too small to further characterize, but obviously give one pause for the possibility of metastatic disease. So there's his films. Dr. Yonesh, can you describe what you see?
I see a right kidney that has what look like cystic lesions and possibly also solid lesions. It's very unusual morphology, and I would like to look at additional cuts to get a better sense of it.
I don't have any, too bad. So basically what you see here is this is a cystic structure of some kind. Here's a solid component right here. And this is a dilated ureter right here. You can see some cysts surrounding the renal artery. So anyway, because of this central lesion here that looked like it could potentially be involving the collecting system, we took him to the operating room to do a retrograde pyelogram, which is basically putting contrast, X-ray contrast, backwards up the ureter. And what it showed was that in fact this is actually a UPJ obstruction. So basically his renal pelvis is obstructed by something, and that's dilated renal pelvis with a atrophied kidney. We couldn't get a ureteroscope up through the UPJ obstruction, but we did send urine cytologies and washings, all of which were negative. So the idea was we were concerned that this possibly could represent transitional cell carcinoma, given its central nature, but all of the evidence would suggest that it's not. So, Dr. Mateen, how would you go from here?
More films would be nice, but assuming there's nothing else going on and there's
Always whining about the films.
yeah.
Go ahead.
But assuming that it's essentially a non-functioning kidney, which is what it looks like, then the thing to do is really remove the kidney. If you're still not sure about whether it's urothelial cancer, then you can have a pathologist kind of look at it right away to tell you, so that if it is, possibly we remove the whole ureter down to the bladder at the same time.
Yeah, so the significance of it being possibly urothelial or TCC, transitional cell carcinoma, is that it changes the operation a little bit. You have to take out the entire ureter all the way down to the bladder if it's a transitional cell because of the risk of recurrence. So you could take out the kidney, have it bivalved by the pathologist. They could do a frozen section and tell you whether or not it's clear cell or not, and then go from there. Anyone disagree with that, management?
So why not take the ureter at the same time? I mean, most of the times, is your pathologist going to give you the answer right there while you're in the OR, waiting to make a decision whether you take the ureter out? If the suspicion is high that it could be a urothelial carcinoma rather than renal cell, what's added 20 minutes, half an hour to take the ureter out?
Well, it doesn't. I mean, it does increase the complexity of the operation, which obviously does increase the potential for complications. If you're approaching this through a flank approach, then that means you'd have to make another incision to take the rest of the ureter out. So there are reasons to get that information at the time of surgery. They usually can tell very quickly whether or not it's urothelial versus a renal cell carcinoma.
Is it possible to do a biopsy first?
Say it again?
Is it possible to do a biopsy
Certainly
first?
you could do a biopsy. That would not be unreasonable, percutaneous biopsy. But I guess my line of thinking was, like Dr. Mateen had said, this was a non-functioning kidney with a solid mass in it and no other evidence of metastatic disease. So regardless of what the biopsy showed, I was probably going to take this patient to surgery and remove it.
Well, if the biopsy shows, urothelial carcinoma, which is bladder cancer, actually, we because this is high-risk disease, we can potentially give the patient. So if biopsy shows this is bladder cancer, actually, it's a totally different management comparing to kidney cancer. So potentially, we can give this patient chemotherapy before surgery to reduce the risk of recurrence.
Okay. Point taken. You could also give them adjuvant therapy after surgery as well, right?
Yes.
Okay. So we took the patient to the operating room. We did a radical nephrectomy, and there's the pathology. He actually had T4 disease. The tumor was invading into the peritoneum. Margins were negative. So it was collecting duct carcinoma. So this is a non-clear cell variant. Dr. Tanier, what's the role for adjuvant therapy in this setting?
I mean, there is no data here, but this is a very aggressive cancer, and a T4 disease is stage 4. So this patient is going to have, unfortunately, recurrence in a short time after surgery. So how we treat this disease, at this time, we treat it as we treat urothelial carcinoma, so it would be cytotoxic chemotherapy. I would give this patient 4 cycles of platinum-based chemotherapy if his renal function is adequate. If not, I think the combination of paclitaxel and carboplatin would be an alternative, appropriate combination.
Eric, would you offer this patient adjuvant therapy?
I would discuss it with the patient. I don't think we have extremely good data on adjuvant therapy in collecting duct carcinoma. I would present the pluses and minuses, say that this is not really data driven, but it's a belt and suspenders approach.
JJ, anything to add?
Yeah, this is essentially very similar to the management of bladder cancer. So normally for bladder cancer, if after surgery, if you have what's called T4, which means the tumor already got out of the original place, or lymph node positive disease, we would give 4 cycles of adjuvant chemotherapy, like what Dr. Tanier just said. So, yes, we would do adjuvant chemotherapy for him.
So we did have a thorough discussion with the patient. He actually consulted with medical oncology, and after that thorough discussion, the patient decided not to get adjuvant therapy. So he was followed with surveillance and actually remained without evidence of disease for 5 years. He moved to Korea. He got tired of flying back to the United States for checkups, so he just said he would come one last time, which was this year, 2016. All during that time, we were following those nodules in his chest. They remained indeterminate, meaning they remained small and unchanged. They didn't grow or change in size. No new ones developed. So there was no concern there about metastatic disease. And then he got a scan this year. And Dr. Jose, do you want to whine about the films and then explain the findings for me?
I'm sure there's a lot more pictures in there. Trying to see, looks like there's a local recurrence.
So he has a area here of local recurrence that's invasive into the vena cava. This is the vena cava. This is the left renal vein going over here to the left kidney. So it's invasive into the vena cava. In addition, he's got some lymphadenopathy here, some enlarged lymph nodes in the interior caval area. So he went 5 years without evidence of disease and then came back with these findings. Dr. Tenier, what would be your approach?
I'm sure you want to biopsy this, although most likely it's going to reflect the same histology from before, but it would be nice to biopsy it. We know that tumors do change over time, and it reflects the intratumor heterogeneity. So I think since we know that these diseases can recur even after resection, if you think that this is resectable, it's good to have some sequencing done of this tumor to try to identify some targets that could help the patient eventually with systemic therapy. So I think if you're planning on resecting the tumor directly, I think you can get that tissue at that time. So I think, there's obviously want to make sure there is no metastatic disease. So CT chest, I don't know if you showed a CT chest done and it's clear.
Indeterminate nodules.
Oh, indeterminate nodules. I think the 5-year disease-free interval is on his side, that it took that long to recur. You could do the surgery, but it would not be inappropriate to consider giving him some chemotherapy first, rather than subjecting for more surgery, especially if these pulmonary nodules represent small volume metastatic disease, and they are not biopsiable because they're small. So, I advocated to treat this patient in an adjuvant setting 5 years prior with cytotoxics. So I think it's reasonable to give the patient chemotherapy, let the disease declare itself. And if these pulmonary nodules remain the same and they are really truly non-metastatic, then you can make a case for salvage surgery post the chemo.
So you would have to, just to summarize, because you went on and on there, you would do a biopsy, then you'd give chemo, and if they responded, you'd do surgery. Is that what you said?
Correct.
Okay. Dr. Gao, what do you think?
So I agree with Dr. Tenier. So definitely I would do a biopsy first, not necessarily because I doubt this is the tumor recurrence. It's to get the tumor tissues so that we can do some biomarker studies to guide future treatment, including clinical trial enrollment. And then, these patients actually respond to chemotherapy quite well, so we can give him chemotherapy first, and hopefully we can shrink the tumors and also the lymph nodes to make the surgery easier.
So you would advocate biopsy followed by chemotherapy and then surgery?
Right.
Okay. What chemotherapy would you give?
If his kidney function is okay, we can do cisplatin-based chemotherapy such as gemcitabine, cisplatin, or MVAC. It's methotrexate, vinblastine, Adriamycin, and cisplatin.
Okay. Dr. Karam, what are your thoughts?
I don't think we need a biopsy, but it's not wrong to get one. I would recommend neoadjuvant chemotherapy and then surgery if the patient responds well.
Dr. Mateen?
I think those are all very reasonable options. I've got nothing more to add.
Dr. Yonesh?
What's his creatinine clearance?
It's 50.
Yeah, so I agree with Dr. Tenier and Gao.
Okay, so I actually presented this case to Dr. Tenier, and he told me at that time just take it out. So we went ahead and took it out. We did an exploratory laparotomy. We resected the mass. We had to resect a portion of the vena cava and reconstruct it with a bovine pericardial patch. And you can see his pathology. All of our margins are negative. 2 of 9 lymph nodes were positive, in addition to the mass, which was invading into the psoas muscle, invading into the vena cava, and also some of the perinephric adipose tissue that had been left. So based on this, very quickly, Dr. Tenier, what are you recommending now?
I was wrong twice, I guess, huh? I think, again, if we made a case to be consistent with what I said earlier, I recommended adjuvant chemotherapy because of the T4, considering that he had a T4 disease, that's stage 4, and the high risk, this is very poorly differentiated aggressive cancer with high risk of recurrence. Again, the discussion is still young. Rather than wait until he has recurrence, same argument, I would give him adjuvant chemotherapy.
Okay. Does anyone not want to give him adjuvant chemotherapy?
I would discuss it with him because he's obviously declined before.
Mm-hmm.
Any role of intraoperative radiation therapy in these types of scenarios? I know there aren't, prospective data, but this patient has a tendency of local recurrence and very aggressive invasion. Is that something that might help or has been used?
I mean, again, this is such a rare disease. I don't think anyone has any experience with it. I guess I wouldn't say it's wrong to do that. We actually didn't consider it at the time of surgery and felt like we got a good margin around it.
I mean, if this patient did not have this histology that's very rare, which is a renal cell carcinoma, but let's say this was a transitional cell carcinoma of the renal pelvis with 2 nodes positive, and I think we would make the case for adjuvant chemotherapy. Again, we're never going to have a randomized trial like we do in bladder cancer or clear cell RCC to really give us a definitive answer about the role of adjuvant therapy, but I think based on he's young and healthy, if he accepts the treatment, I think it is reasonable to offer him cytotoxic chemotherapy.
Okay, let's move on. So this is a 43-year-old white male who presented with right flank pain and gross hematuria. He also complained of some fatigue and weight loss. You can see really no past medical or surgical history of significance. He had a CT scan of his chest, which revealed bilateral pulmonary nodules. He had a bone scan and MRI of the brain, which was negative. He has anemia. His LDH is normal. Calcium is normal. His white blood cell count is normal, and his platelet count is normal. So you can see here that is a lung CT. There's a nodule here in the left lung, a very large nodule here in the right lung at the hilum. And he's got a locally advanced tumor involving his right kidney. And you can see evidence of extension into the renal pelvis, and actually there's also involvement of the renal vein. So, Dr. Jonas, how would you approach this patient?
I would discuss our ongoing clinical trial randomizing individuals between upfront nivolumab versus nivolumab plus ipilimumab versus nivolumab plus bevacizumab, followed by surgery with this patient. I think this is an individual who's an ideal candidate for this approach.
So you would recommend participation in the pre-surgical trial with the immune checkpoint inhibitors followed by surgery?
Yes.
And if you were in the community setting and didn't have access to clinical trials, what would you recommend?
In this individual, standard of care would be cytoreductive nephrectomy followed by systemic therapy.
Okay, and what would that systemic therapy be?
Level 1 evidence currently would suggest sunitinib or pazopanib.
Okay. Dr. Gao, what are your thoughts?
So, here's this one. I would biopsy one of the lung nodules to establish diagnosis, to make sure whether this is, clear cell or any, other types of subtypes of renal cell carcinoma. So suppose this is renal cell carcinoma. I think the 2 options discussed by Dr. Jonas are both very reasonable. But, this is a very young patient, 43-year-old. So I would also discuss with him about high-dose IL-2 therapy, because sometimes you see patients with 2 or 3 young kids, and they really want to achieve that 7% of complete response, which means almost a cure for him. So that would be another option.
So I hear a lot of discussion, but just tell us what you would recommend. If it was you, what would you do?
I have been very successful by recommending this young patients to high-dose IL-2.
So if it was you, you'd do a biopsy followed by high-dose IL-2?
Well, again, it's a discussion. So
Life is a discussion.
It's really, because it's so toxic, some patients wouldn't want to do this.
What would you want if it were you?
If I were this guy, I have, 2 younger kids, I would try high-dose IL-2.
With the kidney in place?
That's an option we can discuss with the surgeons.
How often does the primary respond to high-dose IL-2?
It's rare.
Never. So you definitely would need to have surgery. Dr. Karam, what are your thoughts?
I would want to biopsy this first and see what it is, and once I have the result, I can then discuss with the patient what the options are.
So you would biopsy what?
I would go for the lung. Looks like the right lung lesion is big enough that they can safely get it.
So you'd biopsy the lung, and if it comes back as clear cell, you do what?
Just the same thing as Dr. Yonesh mentioned as far as discussing clinical trial versus upfront cytoreductive nephrectomy.
And if it comes back as non-clear cell, you do what?
Well, if it's renal cell carcinoma, non-clear cell, and he's young with most of the disease in the kidney, I would still do a cytoreductive nephrectomy.
Okay, so regardless of what it comes back, you're going to take the kidney out?
Well, there could be some other histologies that we see, admittedly rarely in our practice, but sometimes you see something that's very different, some types of sarcoma or urothelial carcinoma that we just want to check.
Do you really think this is urothelial carcinoma?
From the 2 images that I'm seeing, it could be, I don't know. That's why a thorough review of the CT scan is advisable.
Have you ever seen a transitional cell carcinoma look like this?
Yes.
Oh, okay. Dr. Mateen, what are your thoughts?
No, listen, I think, first of all, one thing we should consider is he's symptomatic, so it depends how bad the pain is and how bad the hematuria is. If those are really problematic, the thing to do is to take out the kidney first. And it's still within very reasonable standards, could still get IL-2, could still get pazopanib afterward. Having said that, if those symptoms aren't manageable, I think the other option that we have available now is another clinical trial, so that he could get the ablation of one of the lung nodules, one of the more peripheral ones, and then have the clinical trial would determine whether it's just anti-CTLA-4 or cryoablation of the lung nodule plus anti-CTLA-4, and then 3 months later we remove the kidney. So it's an untested approach, but he does meet criteria for that, and again, depending on his motivations, it would be another consideration.
Okay. Anyone have any different thoughts? So I'm hearing clinical trial, and in the absence of clinical trials, cytoreductive nephrectomy followed by systemic therapy with pazopanib or sunitinib, and everyone says they would get a biopsy. Is that true, or does anyone not want a biopsy?
So I think the biopsy would be indicated if you plan to initiate systemic therapy first and then do surgery. If you plan on going in and you made a decision with the patient to take the kidney out because of the pain and the hematuria, and then you want to give the patient high-dose IL-2 afterwards, if it's clear cell, then I think there's no need for a biopsy. Take the kidney out, the lymph nodes, and then if it's clear cell, high-dose IL-2 is certainly still an option and should be discussed with the patient who is young and want to be aggressive. If it is non-clear cell, we have a clinical trial that we're going to open here soon at MD Anderson with nivolumab in patients with non-clear cell RCC who have metastatic disease. So regardless if this patient is interested in clinical trials, we will definitely offer him a clinical trial. The one that Dr. Gao mentioned, he's the PI of that trial. If we do a biopsy and it's clear cell, to get him on the pre-surgical treatment with immune checkpoints plus or minus Bev, followed by cytoreductive nephrectomy, followed by Nivo monotherapy after surgery.
So the patient actually did undergo cytoreductive nephrectomy. The pathology you can see there, T3A-N0M1, clear cell renal cell carcinoma with focal rhabdoid differentiation. Dr. Karam, what's the significance of rhabdoid differentiation?
So that's a histological feature that the pathologist will tell us about, and by definition it's grade 4 kidney cancer, which is the highest grade kidney cancer. We initially thought that it is a additional feature that tells us it's a very aggressive tumor, but recent studies from the Mayo Clinic show that it's basically the same thing as a regular grade 4. which is unlike sarcomatoid, which was mentioned earlier today. So I would just consider this as just a clear cell renal cell carcinoma grade 4 tumor.
Okay, so we did postoperative evaluation with CT scans, and he showed some modest progression on his CT of the chest. No evidence of disease in the abdomen. Everything was removed with surgery. So very quickly, what would you recommend to this patient? Don't tell me you're going to discuss things. Don't tell me there's options. Tell him what you're going to recommend, okay? Dr. Yonesh?
Either clinical trial or TKI.
Which TKI?
I would start him on pazopanib.
Why not sunitinib?
That's also a good choice, but you're not giving us a discussion.
Dr. Mateen.
IL-2, high-dose IL-2 as a first option, TKI second option.
Okay. Dr. Karan?
IL-2 and then clinical trial.
IL-2 and then clinical trial. Okay.
Yeah.
Dr. Gao?
IL-2 as well.
Okay. Dr. Tanier?
High-dose IL-2.
So let me get this straight. We got 8 new treatments for kidney cancer approved since 2005, and you all want to give high-dose IL-2?
I didn't.
Yes.
Okay.
I mean, this is a patient who is 43 and he's healthy otherwise. The only curative therapy that we have right now for clear cell RCC remains high-dose IL-2. Now, it's toxic, but, if the patient understands, what he's getting into and accepts the toxicity for that small percentage of cure, I think it will be appropriate. It's a discussion between the patient and the provider. Now, if the patient says, no, I do not want to get high-dose IL-2, then the trial that he will be enrolled on at MD Anderson right now will be avelumab plus axitinib versus sunitinib. So it's a randomized trial between these two arms. And if he gets randomized to sunitinib, that's a good drug. He may do well on sunitinib for a long time. And if he progresses, or when he progresses on it, then he can get either participate in another trial, or he can get then nivolumab because then he will be eligible to receive nivolumab for salvage.
The reason I didn't recommend high-dose IL-2 is that if you look at the data retrospectively, higher grade tumors like this tend not to respond as well to interleukin-2. So I would obviously have the discussion and mention to it, but I'm concerned that this would be a long run and a short slide, especially for an individual who is actually a little bit symptomatic, suggesting that there's cytokine production by the tumor, and that these are the sort of people that don't thrive on IL-2.
So you had 1 vote for pazopanib, 4 votes for high-dose IL-2. Okay.
So the other point I want to make with high-dose IL-2, so you can have high-dose IL-2, but you will also have almost the same options in the future. You can still be treated with target therapy. You can still be enrolled on most of the immunotherapy trials. So yes, a few weeks of treatment with high-dose IL-2 is very, very tough, but a few months, I mean. But after that, you still have similar options.
Just, Chris, I want to mention that there is a new formulation of interleukin-2 that's pegylated, and the preclinical data suggests that it is much less toxic and more effective than the traditional high-dose IL-2 we've been using for 30 years. And then actually the data is good in patients who had prior therapy with a TKI. So that would be, we have a trial at MD Anderson with pegylated interleukin-2 from Nektar. It's a phase 1. Right now it's open for patients who had prior TKIs, but pretty soon we're going to open it in patients who are treatment naive. So that's an option. So it may be an improved version of the old high-dose IL-2, and consequently, I think more patients may benefit from it than right now the traditional small percentage of patients.
Okay, let's move on to this case. This is a 44-year-old white male who presents with a history of renal cell carcinoma from an outside institution. He had previously been treated with a right radical nephrectomy in 2003 for a T3A disease. He then had a hand-assisted laparoscopic left partial nephrectomy in 2008 for T1 disease. He's got some minor medical problems, urolithiasis, hypertension, coronary artery disease. You can see his medications. CT chest, again, shows bilateral indeterminate pulmonary nodules. MRI of the brain is negative, bone scan negative. He's got an elevated creatinine of 1.98 with an EGFR of 42. And I know you're going to whine about the films, but let me just go through this real quick. So basically, he's got some hydronephrosis. That's what this white area is. He's got an area of recurrence in his kidney right here in the upper pole with evidence of a tumor thrombus that extends into the renal vein. You can see that also here. And here's another view. So again, locally advanced tumor in the central part of the kidney involving the collecting system with evidence of renal vein involvement extending almost to the vena cava. So, Dr. Gao, thoughts?
It looks like he has tumor recurrence in the central portion of the left kidney.
Thank you. What are you going to do about it?
Refer him to the surgeons.
Okay. So, Dr. Karam, you just got a referral from Dr. Gao. What are you going to do about it?
Thank Dr. Gao for the excellent referral. And this is clear cell renal cell carcinoma?
His previous tumors were clear cell renal cell carcinoma, yes.
If I have the option to present options to the patient, I would discuss neoadjuvant therapy followed by an attempt at partial nephrectomy and renal vein thrombectomy.
What neoadjuvant therapy would you offer him?
Pazopanib or axitinib. We have experience with both and with sunitinib as well.
Okay.
That would be an option.
All right. Dr. Yonesh, what are your thoughts?
I'd discuss, if this is not resectable, I would discuss giving axitinib based on your and Dr. Karam's excellent data showing that that's very effective at cytoreducing renal masses and lesions around the kidney.
I mean, I would say it's resectable, but to resect it, you'd have to take his kidney out and he'd be anephric. Dr. Tanir, thoughts?
I mean, if you just said that regardless, you're going to end up removing the whole left kidney and he's going to become anephric on dialysis, might as well just do the surgery up front and spare him any systemic therapy.
No, the systemic therapy, we're hoping that it would shrink it a little bit.
You think you can still do a partial?
We have to try, I think. I mean, the patient looks reasonably thin enough and the anatomy should be hopefully somewhat preserved, although knowing that the patient has had surgery there before, but depends on the images. I think it's worthwhile discussing it and trying it.
Sure, I agree then. If there is a chance you will shrink the tumor and potentially avoid radical nephrectomy and dialysis, then yeah, obviously axitinib would be what I would give him.
So, in all honesty, this is actually a referral from one of your colleagues who's not represented here on the stage, and her thought was to treat this patient with nivolumab, to potentially, quote-unquote, cure him and let him keep his kidney. Thoughts?
So I actually have a different thought. So if this is not resectable, if this is still clear cell renal cell carcinoma, so the pre-surgical trial actually can enroll this patient as long as this patient can have biopsy and also post-treatment biopsy. So we can potentially give him, nivolumab or nivolumab plus ipilimumab or nivolumab plus bevacizumab and see how he responds. If he responds very well, he will get maintenance nivolumab treatment of 2 years. And this way, if he has good response, we can at least let him keep the kidneys for 2 years or beyond, so that will avoid dialysis for him. So that would be an option for him as well.
What are the odds of him responding, you think?
So the odds of response for nivolumab alone is about 30%, and when you combine nivolumab plus ipilimumab, the response rate was about 40%, and when you combine nivolumab plus bevacizumab, so the response rate is not known, but by looking at the data we have now with patients on this trial, the response rate is probably anywhere between around 40%. So he definitely will have a very good chance of having response on this trial.
Okay, so he was enrolled on the clinical trial, but then unfortunately he went into renal failure. His creatinine rose to 3.5 with an eGFR of 20, so dialysis is basically eGFR of 15. And so unfortunately he was not a candidate for the clinical trial, so we took him to the operating room and performed the radical nephrectomy and put in a dialysis catheter. There's his pathology, T3A N0M0. So A couple of questions. I'm going to put first to Dr. Jonas. Is there any role for additional treatment aside from the nephrectomy?
Scans are negative otherwise?
Scans are negative.
I would watch this individual.
Watch the individual, okay. Anyone do anything other than surveillance? Okay, so the guy obviously wants to get off dialysis and get a kidney transplant, assuming that he has a donor. Dr. Karam, what do you tell your patients that are on dialysis with regards to when they are eligible for a kidney transplant?
I honestly am not sure exactly the criteria, but I think there is at least 2 or 3 year wait before they can be eligible for transplant. In general, I would refer them to my colleagues from nephrology for that kind of a discussion, but I tell the patients there is a waiting period. You can't just have the nephrectomy and then immediately get a transplant. There is a waiting period before.
Why is that?
Because if the patient has metastatic disease, a year or 6 months after surgery, I think that will be that will interfere with the medications they have to be on for immune suppression for the transplantation, and that might make the cancer worse potentially.
Yeah, so the message is basically if the patient does have microscopic metastatic disease, whenever someone gets a kidney transplant, they have to have their immune system suppressed. So immunosuppression plus cancer is bad, very bad. So typically they'll make them wait at least 2 to 3 years before they'll be considered a candidate for a transplant.
Chris, any thought or insight about why he developed acute renal failure?
I think he actually showed progression of his tumor thrombus and obstructed venous outflow to the kidney. Plus he was having some gross hematuria, so he might have had some obstruction. There was hydro in the film.
So we share other patients, some of my surgical colleagues share patients where we've seen similar things where the metastatic deposits, distant metastatic deposits might actually shrink, but then the primary tumor remains the same size, or there can even be an increase in size, although when you biopsy those areas, you see that there's only necrosis. But you get this heightened necrosis and infiltrate of tumor cells, immune cells, and in a place where you've got little room and the guy's already symptomatic, you'd be worried that you're actually going to make the renal function worse.
Okay, let's talk about this case. This is kind of an interesting case. So this is another patient with a history of renal cell carcinoma. Had a right radical nephrectomy in 1999, then had a left partial nephrectomy times 3. So he had 3 separate tumors in his left kidney that were removed in 2000. He was followed with surveillance and did well for 5 years, and then he presented for follow-up in 2005, and he was told that he had at least 7 tumors in his remaining kidney, and he was offered a radical nephrectomy. His past medical history significant for seminoma. He had radiation to his retroperitoneum in addition to the orchiectomy. It was stage 1. He came to MD Anderson for a second opinion. His CT showed those same indeterminate pulmonary nodules. So, Dr. Karam, can you describe what you see?
So on the left-sided picture, there looks like there is a hernia with the liver coming out of the abdominal wall. On the left kidney, there is a mass. On the second picture, it looks like there's at least 2 other masses, maybe a third one even deep in the parenchyma.
So here's a guy with 1 solitary kidney with multifocal disease present in that kidney. There's one other finding on the CT that Dr. Karam did not point out that I'll point out now. He has a hypervascular area in his pancreas, which is consistent with metastatic disease to the pancreas from his kidney cancer. Dr. Mateen, how would you manage this patient?
What's his GFR?
GFR is 40.
Okay. Yeah, I think based on what I see, he's eligible for partial nephrectomy. Wouldn't be the easiest, wouldn't be the hardest. I would do it because he's at risk for local progression and going into kidney failure, which in the setting of metastatic disease really is just not a good situation to be in. He could be considered for a clinical trial first or systemic therapy first based on the pancreatic met. Potentially he's got a nodule in his lung as well.
Indeterminate pulmonary
Indeterminate, so who knows. Patients with pancreatic metastases do actually very well. I sometimes wonder whether they do well despite what we do. You read reports where they're left alone and they do great. You read reports about there's aggressive surgical intervention, they do great. You read about how they get systemic therapy, TKIs, they do great. So it portends the biology of this disease, which you've kind of seen played out. He's had now cancer for 6, 7 years straight, and has actually overall done quite well. Unfortunate scenario as it may be now, but it's still quite reasonable.
So again, your recommendation would be what?
I would consider aggressive surgery in this patient. Partial nephrectomy, maybe even have a pancreatic surgeon take a look at the resectability of the pancreas. It's not quite far away in the tail where it's a little bit easier, so that may make it a little bit tougher. If that's the case, then I would leave that alone.
Okay. Dr. Yonash, what would you do?
What's his family history?
In terms of what? Genetics? No history of renal cell carcinoma.
Okay. And any other cystic lesions anywhere? So other people who get multifocal bilateral clear cell renal cell carcinomas and enhancing pancreatic lesions could also have a pancreatic neuroendocrine tumor from VHL disease. And so that's something that one would want to explore here. So to say that that's definitely a MET in the pancreas, you need more information.
Okay.
And
that information would be what?
That information would be you would do genetic testing on the individual and see whether or not they have a genomic lesion. It's very straightforward, very easy to do, and would be something that would provide you information on that. And even if they don't have a family history, they could, about 20% of individuals with VHL disease do not have familial antecedents. So that would be part of the strategy here. With regards to systemic therapy to shrink things down to assist with surgery, I mean, it's certainly something that one could consider, but I would do that in collaboration with my surgical colleagues.
Just out of curiosity, what agent would you select if you were to select one?
Yeah, I mean, if you, again, with your data with cytoreduction frontline, so low stage or low grade type tumors, it looks like axitinib's very good at cytoreducing. It's clear we do the same thing with pazopanib, which we have the most experience with, and to a lesser degree sunitinib. But I would pick axitinib just because of its relative lack of complexity with regards to following liver function tests, et cetera.
Okay.
And if we can get it covered.
All right. Dr. Tenier, what are your thoughts?
I would consider systemic therapy rather than surgery in this patient who has multiple lesions in the left kidney, a lesion in the pancreas, and pulmonary nodules, even though they're small, indeterminate, but they're most likely metastatic. So I would not do surgery up front. I would enroll him on Dr. Gao's protocol, get a biopsy of whatever is amenable to biopsy. I think the pancreas or more easily one of those lesions in the kidney, biopsy it and get him on the pre-surgical protocol with nivolumab versus nivolumab plus bevacizumab versus nivolumab plus ipilimumab.
Suppose you didn't have that protocol available, what would be the standard of care in the community?
I would not do surgery in this patient. I would treat him with a TKI.
Which one?
Sunitinib or pazopanib.
Okay. Dr. Gao, what are your thoughts?
I actually completely agree with Dr. Tenier. In this setting, if we can use any agent such as TKI to, shrink the tumor, maintain stable disease to disease regression, I think keeping his kidney for a longer period of time will be a good option.
All right, Dr. Karam, what are your thoughts?
I would want to know what the pancreatic lesion is. I agree with Dr. Yonash about that. If the patient has metastatic disease into the pancreas, and like Dr. Mateen said, it's not at the very tail of the pancreas, he might need major pancreatic resection. In that case, I would not do surgery. But if the lesion is surgically resectable with just a distal pancreatectomy, I would discuss it with the patient and offer surgery. Now, if the pancreas is not metastatic kidney cancer and all his renal cell carcinoma is localized to the kidney itself, looks like the renal lesions are, reasonably resectable. They're very well demarcated, and they're not very large at this point.
Okay, so again, what would you do?
Biopsy pancreas.
Biopsy pancreas. And if it's renal cell carcinoma?
And it's not surgically resectable, then I would not offer surgery for the kidney even.
Okay. So I'm glad we have a consensus. So Dr. Yonash says systemic therapy followed by surgery. Dr. Mateen says surgery followed by maybe systemic therapy if there is evidence of growth. Dr. Karam says biopsy the pancreas. Dr. Gao says systemic therapy followed by surgery, as does Dr. Tenier. Okay. So the patient was referred for high-dose IL-2. Kills me. And actually developed renal insufficiency, so they had to stop after like 3 treatments. He progressed on therapy with enlarging axillary lymph nodes, so he was started on sorafenib with dose escalation. And he actually had no evidence of disease progression for 4 years. And then at 4 years, he was changed to sunitinib because of evidence of disease progression. And then the patient complained of a cough and a hoarse voice, so they got this CT scan of the neck, and you can see that he's got an enhancing lesion here in the hypopharynx. Dr. Karam, what do you think?
I think he needs a referral to one of our colleagues from head and neck surgical oncology.
Okay.
Just for evaluation to see if any local therapy can be done for this.
Okay.
In
Anyone
addition to
disagree with
switching.
that, sending him to head and neck for possible surgery?
Not surgery, for evaluation.
Okay.
Yeah.
Is there a change in systemic therapy in order, given this progression?
I would biopsy it. I mean, I agree, send him to head and neck surgery for evaluation and biopsying it. If this is, again, recurrence or progression of the clear cell RCC, change of therapy is in order. I mean, we have many options here. Immune checkpoint inhibitors, nivolumab would be an option, cabozantinib would be an option, axitinib would be an option. So you said he had only sorafenib followed by sunitinib, right?
He had high-dose IL-2, followed by sorafenib, followed by sunitinib.
Okay, so he still has many other options of therapy, the ones that I mentioned. So, I mean, he can get nivolumab, axitinib, or cabozantinib, or participation in a clinical trial.
So, I just want to say, before we take credit for the fact that he's done reasonably well for 4 years, I think, again, it just speaks to the biology of the disease primarily. And I would still argue that instead of exposing him to poison for 4+ years, he could have had surgery and had very similar outcome. And then you preserve the sort of the subjection to toxic systemic therapy until the patient really needs it.
So the patient was sent to head and neck. They did a robotic resection of the lesion in the hypopharynx. He was continued on sunitinib, but was not thought to be progression. And after 2 years, he started developing worsening of his renal function and developed actually proteinuria consistent with nephrotic syndrome. So sunitinib was stopped for a couple of months, and then he was started on everolimus. And he took everolimus for 2 years and demonstrated evidence of progression. Then he was started on axitinib. So now we're talking, what is this? This is
8 years.
Fifth line?
8 years now, huh?
Yeah. So he progressed on everolimus after 6 months and was started on pazopanib. This was poorly tolerated due to toxicity, and he had mild progression on therapy in large part because he couldn't tolerate the dosages. Then in 2015, he developed gross hematuria with clot retention. At an outside institution, they tried to do selective embolization of the bleeding tumor, but they failed, and then ultimately he ended up on dialysis. And he continues to have gross hematuria with clots. Dr. Mateen, would you like to say I told you so?
Yeah.
Go ahead.
I told you so. I mean, it's so easy looking back. I'm obviously just trying to stir the pot here, but it's very easy to look back and pass judgment. But I still think he would have been a better surgical candidate. But yeah, at this point, in terms of what we need to do now, he's symptomatic. If his performance status is, if he can undergo surgery, then
performance status is probably like 2.
Oh, yeah.
See, locally advanced tumor involving the left kidney, and probably a little bit of renal vein thrombus going on.
Yeah. Yeah, just a matter of assessing whether you need to take the kidney out and just give him some quality of life for what's left of it, or see if this can be kind of managed conservatively without surgery.
Okay, what would that conservative management be?
You don't have many options left. I mean, there really isn't much. You can maybe try another form of systemic therapy, but on dialysis, I know it becomes quite difficult.
Dr.
Where does he have metastatic disease right now?
So he has metastatic disease in the chest. He had metastatic disease to his hypopharynx. He has metastatic disease in his pancreas. He has a implant in the soft tissue of his flank from his previous surgery on the flank on the right-hand side. He has positive biopsy axillary nodes. So he's got pretty widespread metastatic disease.
Okay. Is it high volume? Because clearly it sounds like from a symptom relief perspective, a surgery may be appropriate if his performance status is otherwise good and he doesn't look like he has a major risk or threat from his other sites of disease.
He doesn't have high volume disease, but his performance status is too. I mean, this guy he's been through the ringer. He's gotten virtually every targeted therapy there is. He's got significant toxicity related to his current agent with pazopanib, so he's at least a 2.
Yeah, I'd see what happened. I would recommend this. He undergo surgery to improve his symptoms from his kidney, and then see what happens post-surgically. Repeat imaging studies 8 weeks later. If he demonstrates relative stability of disease, I would allow, I would recommend that this individual perhaps go under a period of observation just to see whether or not we can get performance status to improve before we consider other therapies.
Okay. Dr. Karam, what are your thoughts?
Since they only tried selective embolization before, I would talk to the radiologist and see if there's any role for embolizing the entire left renal artery.
Mm-hmm.
That might be another option that could stop the bleeding without, having to do an operation.
Okay.
The other option that we don't really do and historically has not been considered, but some people are starting to look at it again, would be high-dose radiotherapy to the area. Historically, we don't think that kidney cancer is susceptible to radiation therapy, but with some of the newer forms, where they can deliver really high doses in very short, in just a few sessions, it essentially would be high enough to essentially kill the kidney, which it's already not working. So that would be a potential to be considered. Again, we don't do it, but there are some groups that are looking at doing that.
Is there any role for just changing systemic therapy and hoping for the best?
So if you can control the bleeding, the symptoms, if he stabilizes, I think we can try nivolumab because he hasn't seen any immunotherapy yet.
But how can you control the symptoms?
Just with the measures that you guys just discussed about a moment ago.
I would send him for left radical nephrectomy and hope that he will be in good shape post-operatively to resume systemic therapy with nivolumab, although there is no data of giving immune checkpoint inhibitors in people on dialysis. And that would be a challenge, but still, if he post-operatively, he has progressive disease, but still is in good shape, reasonable shape to receive systemic therapy and is willing to consider nivolumab, then I would treat him with nivolumab post-nephrectomy.
So he was taken for a left radical nephrectomy, and actually a splenectomy was required because of the significant amount of reaction present in the retroperitoneum related to his previous surgery. He still had multifocal renal cell carcinoma. There were 3 tumors, the largest of which was 11 centimeters. He also had a metastasis in his left adrenal gland. So I think we've pretty much said what we would do. Just to go down the line, Dr. Yonesh, what would you do now?
So a period of observation to allow him to recover from all of this. Definitely, if there's growth, a checkpoint antibody would be appropriate next step.
So nivolumab. Dr. Mateen?
Agree.
Anybody disagree? Okay. So let's go over this case. This is a 46-year-old white male who presents with hemoptysis, so coughing up blood. Past medical history significant for hypertension and asthma. Previously had an appendectomy, also a vasectomy, had an MRI of the brain and a bone scan, both of which were negative. And you can see this patient has a large tumor involving the apex of his left lung, also some nodules present in both lungs. And he has a very large tumor involving his right kidney here. And this is a sagittal section. You can see it's involving the mid to upper portion of the right kidney. It pushes on the liver. There's no evidence of any venous involvement. So, Dr. Tanier, what would you recommend for this guy?
Biopsy. I'm concerned about the hemoptysis.
What would you biopsy?
Whichever is, I think the kidney in an area where you avoid the central necrosis, so you can get some tissue to give you a diagnosis. Or biopsy. Can we go back to the lung CT? Yeah, that's a little bit tricky to get to a biopsy, and they may be able to get it through bronchoscopy. So I think it's reasonable to send him to pulmonary, to a pulmonologist for bronchoscopy to see where the bleeding is coming from. And those patients with RCC and lung mets, especially if they have hemoptysis, the disease tracks into the tracheobronchial tree and it is often you can make the diagnosis during bronchoscopy and seeing an endobronchial lesion, similar to what you see in people with lung cancer, and then get tissue there and get a diagnosis. And with that, then I would proceed with systemic therapy first rather than surgery because of the hemoptysis and metastatic disease. So if the hemoptysis is controlled with the bronchoscopy, YAG laser, or resecting, fulguration, whatever, then I think he may get, if he has clear cell RCC, he will be a candidate for, again, Dr. Gau's protocol with pre-surgical Nivo versus Nivo plus AP versus Nivo plus BEV. The only concern is hemoptysis with BEV, but hopefully this will be controlled with bronchoscopy and local therapy to the lesion.
So bronchoscopy, followed by biopsy, followed by potential participation in a clinical trial. And if a clinical trial is not available, what would you do?
Systemic therapy first.
With what?
A TKI, cemiplimab pazopanib.
Okay. Dr. Gao, any difference of opinion?
Yeah. Mostly, I think I agree with Dr. Tenier. Depending upon how bad the hemoptysis is, if it's really bad, we need to send the patient to pulmonary to work up because that can be life-threatening. And if we see lesions, of course, we can do biopsy. As far as systemic therapy, in this setting, this patient may not be eligible for the pre-surgical trial because one of the major side effects for Avastin would be hemoptysis, bleeding from the lungs. So probably this patient will be ruled out for that trial. But that doesn't mean other systemic therapy is not possible, such as TKIs.
Okay. Dr. Crom, what are your thoughts real quick?
In addition to what Dr. Tenier and Gao said, would radiation therapy for the lung work for the largest lesion for control of hemoptysis, in addition to targeted therapy, of course?
You're asking me or telling me?
I'm asking you.
I have no idea. Dr. Mateen?
No, I would not. Hopefully we have been able to control hemoptysis without radiation, especially if the patient has not been treated before with systemic therapy or local therapy. So this patient could very well be managed with bronchoscopy, and again, removing the tumor from during bronchoscopy that's causing the bleeding. Now, if the bleeding is...
he just had one episode of hemoptysis.
Okay. So the other option of treating hemoptysis, if this is not just one episode of minor hemoptysis, but if it's significant hemoptysis, then embolization. You do embolize the bronchial arteriole. So we would refer him to interventional radiology. But first start with pulmonary evaluation, bronchoscopy. Hopefully you can manage that minor hemoptysis with the bronchoscopy, during the bronchoscopy. But if it is serious, then embolization by interventional radiology. Then you move on and treat with systemic therapy with a tyrosine kinase inhibitor off protocol if the patient is not a candidate for a clinical trial or a trial is not available.
Okay, Dr. Mateen?
Yeah, clinical trial, if it's available. The other one he would be eligible for would be the immunoablation trial that I mentioned before. But if he does not want to participate or is not a candidate, the thing to do would be a cytoreductive nephrectomy. By nature of that, we're removing the overwhelming majority of the tumor, and then he's a candidate for other therapies.
Anything different?
Nope. So question,
You're going to biopsy the renal mass.
Can we go back to the...
Only in the setting
chest
for
CT?
considering a clinical trial.
So just to offer a different view of what Dr. Mateen mentioned, if you go back to the CT chest, please. So that lesion in the left upper lobe, Serena, I think our radiology people will find it a little bit risky to do an ablation to this because it's very close to the vessels, and that would be probably a relative contraindication to do ablation onto that lesion, especially with him having hemoptysis and that lesion. So I would avoid ablation in this particular situation.
Well, he's got other, I don't want to get too much into the weeds. He's got other nodules.
Mm-hmm. Yes.
Yeah, and that one's not really near a bronchus. It's hard, he may have an endobronchial lesion that's not diagnosed. I actually think the bronchoscopy is perfectly indicated to do, because I do worry about the potential for an endobronchial lesion, which has other downstream consequences.
So in fact, he was started on, enrolled in the immune checkpoint pre-surgical trial. JJ, this is your patient, actually. And he got 2 courses of nivolumab and ipilimumab with a fairly significant response. You can see a fairly good reduction in that pulmonary lesion there, and also had significant shrinkage of his primary tumor. And there's another view there. You can see that the primary tumor shrank rather significantly. And he underwent right radical nephrectomy. He had 2 positive nodes, less than 5% sarcomatoid dedifferentiation, but importantly, almost 3/4 of the tumor was dead, related to treatment effect. And they also noted that there was some disease in the nodes, but also that was dead, related to treatment effect. So, Dr. Tanier, what are your thoughts now?
So this is the trial that I recommended for the patient.
Good job.
Yeah. I think continue with immune therapy post-op, nivolumab monotherapy, 3 milligram per kilogram every 2 weeks for 2 years as per protocol.
So, and then what happens after 2 years?
I think we don't know. There is no data. There is no data how long to treat patients with immune checkpoint inhibitors. But I think 2 years, if a patient has this gratifying, impressive response, I think 2 years sounds like it's the right time. And I don't think beyond that, if he achieves a complete response, you can stop therapy. I would stop therapy then.
How much is a dose of nivolumab?
What's that?
How much is a dose of nivolumab?
You mean cost?
Yes.
Well, it's free on the trial, but probably $10,000 every infusion.
It's actually the AWP for this drug is about $13,000 per month. It's not very different from anti-angiogenic agents, but the infusion costs are higher, and then institutional markup makes it pricey.
So it's like $20,000 every 2 weeks, right, with the markup?
$17,000.
$17,000 every 2 weeks. Wow.
Every 2 weeks.
Anyone have any other thoughts besides continuing nivolumab? Okay. We're good on time. This will be our last case. So this is a 59-year-old African-American gentleman who presented with hematuria at an outside facility. He was told he had numerous tumors in his right kidney and he needed a nephrectomy. He had no evidence of disease elsewhere. So he underwent a radical nephrectomy in February of 2015. You can see he had both clear cell as well as type 1 papillary. The maximum tumor size was 6.7 centimeters, making him T1B. So he comes back a year later for follow-up. He's told, now you got a bunch of tumors in your other kidney, and we're going to refer you for ablation. So he came to MD Anderson for a second opinion. His CT scan of the chest was negative. So just for the interest of time, you can see he's got a tumor here in his left kidney. He's got another tumor here in his left kidney, maybe something here in his left kidney. He's got another tumor at the inferior aspect of his left kidney. He's got a tumor that's largely interparenchymal in his left kidney. So multiple tumors present in the left kidney, no right kidney. Dr. Mateen, what are your thoughts?
Yeah, this is an interesting presentation. We actually see this. African Americans do seem to have, I have a large number of these patients with bilateral multifocal papillary type 1 kidney cancers. We don't understand why that happens. It doesn't appear to be anything genetic that we can identify. There's been now suddenly some interest academically to look at this. I would offer a partial nephrectomy. I would certainly not take out the kidney.
So you would offer partial nephrectomy, any role for ablation?
Not for those multiple tumors. I would maybe hold that in reserve for the very likelihood that he would recur down the line, and I would have that as a backup plan. But okay. To address all of these with ablation might be somewhat difficult.
All right. Anyone have any different thoughts about that?
I mean, again, in my talk, I talked about papillary RCC, and some patients may have inherited syndrome type 1, and so this, he's a little bit older for an inherited syndrome, but we do see patients who are older than the 40s or younger. So I think genetic testing of his germline mutation. I think we need to find out if the patient has a germline mutation of c-Met. Those are the patients. If he has germline mutation of c-Met, that's responsible for his papillary type 1 RCC, those patients may respond to very well. As I showed in that Foretinib phase 2 trial, 50% of those patients had a partial response with an agent, a kinase inhibitor that blocks c-Met.
So you're saying biopsy and do genetic analysis?
Well, I mean, you could do both. I mean, you can get genetic analysis and see if he has a c-Met alteration, and if he does, it might be something to consider to treat him first and see if those tumors go away with the drug, and spare him multiple partial nephrectomies that could result into renal failure or chronic renal insufficiency, leading him to dialysis pretty soon.
All right, so we got one vote for systemic therapy, potentially after a biopsy, and the rest say surgery? Is that right?
Again, the systemic therapy with just one agent, not any TKI, but to treat him with a c-Met inhibitor if he has alteration of c-Met.
So the patient did undergo left partial nephrectomy times 4. All tumors were T1A. There was both clear cell and papillary. He was told to stay in Houston after his discharge for a couple of days, but he ignored that advice and went back to Louisiana. He decided that the weight restrictions we put on him were excessive, and so he lifted something heavy at home, and he developed gross hematuria. The patient was passing clots and developed renal insufficiency with hydronephrosis, so a stent was placed, and then he was transferred back to MD Anderson. He had persistent gross hematuria with worsening renal function despite the stent. So his baseline eGFR after surgery was 53 before surgery, 38 after surgery, and it declined now to 22. Dr. Karam, what are your thoughts?
I would repeat the imaging to check, make sure the stent is in good position, and check for any hematomas outside of the kidney.
What imaging would you get?
CT scan. Unfortunately, we cannot give an IV contrast. It will be just a non-contrasted CT scan.
Without contrast, okay.
I want to
just
double.
a minor fluid collection around the kidney, nothing else.
The stent is in good position?
Stent's in good position.
What's the hemoglobin situation?
He's required transfusion of 3 units now, and his hemoglobin is 7.5.
Is it stable?
No.
So he needs to go back to radiology for another embolization. But I would prepare the patient
He
with
hasn't
IV.
had an embolization yet.
Or he needs to go for embolization. I would prepare the patient with IV fluids, give him some Mucomist, just to make sure he's as ready as possible for the procedure.
Okay.
If his hemoglobin was stable, I would not send him for embolization.
But Jose, embolization with GFR of 22? I mean, you're already committing him to end-stage renal disease.
Not necessarily. He could be also, the GFR could be declining simply because of the blood clots, and that could potentially improve. But that's why I said if hemoglobin is stable, I would not embolize him. But
he's had no evidence of hypotension, no drop in his blood pressure, or anything like that. I mean, he is bleeding. He's got blood in his urine, passing a few clots, but not unstable on the floor.
Yeah, no, listen, I think, so what we worry about is that he may have a pseudoaneurysm, which probably is not going to get better on its own, but it's reasonable to observe him for a little while if he's stable. Mm-hmm. But with multiple blood transfusions, persistently low hemoglobin, you do worry. Nizar's point is perfectly on, he's on point. He's at risk with angioembolization for renal failure, but he may be headed that way with persistent bleeding also. So if you go that route, which I think we're headed to, I would prepare him for the possibility of temporary dialysis, which with the risk for potential permanent dialysis.
Okay. So suppose you monitored him and you monitored his hemoglobin, and let's say his GFR dropped down to 15. What would you do?
Oh, and he's still bleeding?
Yes.
Yeah, I'd prepare him for angioembolization and potential dialysis with the hopes that hopefully he would recover and, we'd stop the bleeding and as well his kidney function would recover over time.
Okay. Do you wish we had let Tanir give him the systemic therapy instead? Any other thoughts?
I think, it's a great idea and it's untested. But, I think in terms of future, we have to look forward to the future. That would be the best, really. Clearly there's some sort of predisposition and, if we can find some non-surgical means of slowing it down or even stopping it, that really would be ideal. We're not there yet.
Any other thoughts? So this is actually the first time I've ever seen this. It was pretty impressive. So we did do angio, and you can see, specifically what you can't see in this picture, which is of note, is that you don't see a kidney. And the reason you don't see a kidney is because there's a communication between the main artery of the kidney and the vein. And so basically, he had an AV malformation or pseudoaneurysm where the artery communicated with the vein. So essentially, as a consequence of this, his kidney was ischemic, and that's why he was developing renal failure. And what we did was we embolized this communication, and his GFR improved to 44 after embolization. First time I'd ever seen something like that. Does anybody in the audience have any questions?
But you do see pseudoaneurysm post-partial nephrectomies.
Less than 5%, but you do see it, yeah.
Yeah.
Mm-hmm. Questions from the audience?
But, so, Chris, this is the first case that you see post-partial nephrectomy that resulted in AV malformation?
No. It's the first case I've ever seen where, because of the communication between the artery and vein, the kidney was relatively ischemic, and that's why he had renal failure.
I see.
That was the part I couldn't figure out. I mean, his hemoglobin was dropping, and I got that, but why was his kidney function getting worse? Because he wasn't hypotensive, he wasn't on any nephrotoxic drugs, nothing. But his kidney function on a daily basis was deteriorating. It was because it was chronically ischemic related to this.
And it was not, as Jose mentioned, blood clots blocking the urine?
No, because he had a stent in. All right, well, question. Yeah?
What is the age of the youngest person in your RMC trials?
9 years old.
The question was, what's the youngest patient that Dr. Tenier is treating with renal medullary carcinoma, just for the video. Mm-hmm. All right, well, have a great rest of your weekend. Thank you for coming. We really appreciate it, and hope we will see you next year.
Thank you all.
Thank you.